Good morning to our CCC Live Structural Heart Transcatheter Intervention in collaboration with Fuwai Hospital uh, structural cases, which will be shown today. And we have an excellent team from both sides, from Fuwai Hospital, China, and Mount Sinai Medical Center. So the way it will run, first we'll show one case, which was done as a case in box from Fuwai Hospital, and Professor Pen Zaibin, who is the vice president of the Fuwai Hospital, is one of our key moderator, along with the other team members, which he will introduce and show a case of TEER, which is transcatheter S2S repair for severe mitral regurgitation in appropriately indicated patient. That will go on for about 50 minutes with the presentation and discussion. And then in about, this is start at 8 o'clock. And then by 8:50, we'll end this presentation. Then 9 o'clock, we'll start a live case of catheter tricuspid valve replacement, which is TTVR. Patient has a prior tricuspid valve surgery before and now presented with severe tricuspid valve degeneration. And that case will be live shown by Mount Sinai Cardiac Cath Lab. With that note, I will just hand over to Dr. Pen Xiangbin to continue a presentation from their side and teach us about this very interesting TEER case.
Hello, Dr. Sharma. Let's start the case presentation.
Sure.
This is,
Yes.
Shall we go on? This is a 70 years old male. She had a transapical artificial chordae implantation 2 years ago. Right now, the mitral regurgitation is 4+ grade, and the regurgitation is mainly located in A2, P2 area and partially in P1 area. And VC is 7.6 millimeters, and the EROA is 1.1 centimeters square. And the orifice of the mitral valve is 4.5 centimeters square. LVED 51 millimeters, and the LVEF is 66%, and LA is 58 millimeters. First, let me show you the transapical artificial chordae implantation. This is a Chinese-made device. 这个 ，OK， 没事。那对方看到没有？Okay. Hello, can you see the screen? This is a X-plane view, and the left is back home view, and the right is is a LVOT view. And so we can see because the artificial cordy implantation, there is a plaget on the post leaflet. So from this view, from the back-com view, we can see the so we can figure out the plaget.
And this is done surgically, right?
Hello, can you see the echo?
Yeah. Yeah, we can see that. Yes.
Okay. So we know we have done the artificial cordy implantation 2 years ago, but right now we found the cordy ruptured, and 2 years ago we used the Chinese-made device MicroStitch to the transapical artificial cordy implantation, and we did edge-to-edge repair, use this artificial cordy. But today we found that because of the rupture of the cordy, there is a huge mitral regurgitation. And from this view, we can figure out the plaget, the gasket on the leaflet, and also we can figure out the ruptured cordy. This 3D emphasis view. So we can figure out the nearly the P2 and the P1, there is a posterior prolapse, and also the A2 prolapse.
Yeah.
And the main challenge of this operation was that the previous artificial cordy has broken, but the gasket is still on the leaflet and is relatively stiff and lacks mobility. So from this true view, we can figure out the remaining gasket from previous operation here. I think this is a gasket left on the posterior leaflet. And the prolapse gap is about 7 millimeters. And the prolapse width is about 16 millimeters. And this is a pulmonary venous reflux. Then, let me show you the recorded case video. Hello, can you see the video?
Yep, very well.
Yeah. And then we make an X-plane view. The left is a BICOM view and the right is LVOT view. And we sweep from medial to lateral.
Right.
And so this is color. This is a grade 4 MR,
yep.
And mainly in the P2 and the P1 area. And also we can figure out the broken artificial cordy, and also on the posterior leaflet we can figure out the gasket, the plaget also. This is 3D emphasis view. Yeah, this is a prolapse area. So this is severely regurgitation. So our strategy, the first, we think about using the convergence strategy. So we think we make a clip in the P2 area, and then medial side to the medial to the prolapse area, the second one. And then we, according to the regurgitation, then we will decide if we need to deploy the third clip. And then we are going to deploy the first clip in the P2 area, P2A2. Here we measure the length of the posterior and anterior leaflet. So here we can see we can figure out there is a gasket or pledget on the posterior leaflet, and also the broken artificial cordy. Here we measure the pre-procedure mitral valve gradient. Our strategy is to do the mitral clip case procedure with pure echo-guided technique. Our team, Dr. Pan lead our team. 2 years ago, we started to do the mitral clip with non-fluoroscopic technique with pure echo-guided. And until now, in China, it has been finished 1,000 cases of mitral clip, and including that, 300 cases were finished by a pure echo-guided technique.
Wow. But no fluoroscopy. I know we use a little bit, but clearly that some fluoroscopy we still need. But you are saying that you have done a cases without fluoroscopy at all.
Yes,
yeah, you are right. We only use echo. We use echo to take the place of fluoroscopy completely, because we have many patients suffering from cancer. The patient have lung cancer, so we cannot use fluoroscopy for those patients. And not only for heart valve disease, also for congenital heart disease, we use echo guide procedure for more than 10 years. Yeah, many disease, ASD, VSD, PDA, including pulmonary valve, aortic valve, including coarctation implant stent, and appendage occlusion. We only use echo, totally only use echo, and can protect not only patient but also doctors. So now we are preparing to puncture the septum, which to help our echo is very clear to find the puncture sign. So we also have some technique to make sure you insert the catheter according to the working length. It will be made the procedure safer because we don't use X-ray, totally only use echo. So Dr. Xie is advancing the wire, and echo can show us the wire past the IVC and going up to the SVC.
So actually, I wanted to interrupt one. Our expert, the surgical director of structural heart, Dr. Gilbert Tang, has joined, and he actually, Gilbert, they're showing a case where they put an artificial chordae transapically, and now the chordae have ruptured, and this is the case of TIA. And Gilbert, you can unmute. Maybe we can show the previous. I know we have gone forward. This is the recorded case, and they say that all cases they do, or quite a bit, just by fluoroscope, by echo guidance, and no fluoroscopy at all, zero.
Hello. Hi,
Hi,
你好。
Here, yeah, I see you.
他来了，你看啊，Hello, Dr. Tang and Dr. Sharma. Then we go on.
Yes.
Yes, this the left is back cable view and the right is short axis view. And here we are checking the puncture site.
Yeah.
But right now, the catheter is in a ovalis fossa. Yeah, fossa ovalis. Yeah, and we choose the posterior and maybe a little bit inferior. So here is the tenting. And then we measure the puncture site, the length from the puncture site to the mitral valve annulus. So it's about it's more than 4 centimeters. And this is 4.3 centimeters, the puncture height. And then we did puncture. So from the screen, you can see we don't use the DSA device. So right now the wire is in the left atrium, and we advance the wire into the pulmonary vein, and then we exchange it with the London Quest valve. And now this is the SGC advanced following the London Quest wire. Here the SGC is coming and cross the septum. Now you can see the SGC is in the left atrium. Then we adjust the mitral clip to do the steering to the mitral annulus. we adjust the M naught. Here, this is the warfarin bridge. If you have any comments, please ask us.
Yeah, so great case so far, very nice imaging. So we typically don't use the Lundquist except for TMVR replacement because we worry about left atrial injury. So we typically use Safari wire. What are your thoughts on the wire choice?
So we use London Quest because sometimes if we cannot advance the wire into the pulmonary vein, so we can use the London Quest and to pre-remodel the tip of the London Quest to make three circles. And so the top of the London Quest do not need to go into the pulmonary vein, just in the RA is okay. And we can also do to advance the SGC into the left atrium.
Okay, I see. 明白. Thank you.
Thank you. Let's go on. Here, the clip is near the mitral annulus. A 3D view, we do the orientation. So Dr. Sharma, Dr. Tang, you can figure out we are aiming at the prolapse area, and our strategy is to do the first clip medial to the prolapse area. This is the first one. So almost in the P2 area.
Yeah, I agree. I think we typically look at the width of the prolapse and decide how many clips to implant, number one, and number two, where to implant. So you can see that there is the first area, a little bit more medial, as you mentioned.
Yes, because this is the first case we do the mitral clip for the artificial chordae broken case. So we concerned about the gasket on the posterior leaflet. We are not sure about if we clip the plaget. We concern about the stability. So first we do the first clip medial to the plaget area. So here, this is the orientation. It's a 12 o'clock. Just the medial to the prolapsed posterior leaflet. Very close to the prolapsed area. And we use this view to the trajectory. Then we advance the clip into the left ventricle. We open the clamp, the clip. Ready to do the grasping.
I think it's important for the audience to know. You can see how you have an excellent bicombinatorial view to the grasping view. So your apex is at 6 o'clock on your echo. And also you can see your clip trajectory is excellent. So in the atrium, initially looks a little bit more aorta hugger, but now you corrected it. So when you come to grasp, it's a perfect alignment with the leaflet coaptation plane. So it makes the grasping much easier, as you have shown nicely here.
Yes, yes, we did. We use the plus knot to do the counter aorta hug action. Yeah.
Yeah, this is great. So this is for, you're an expert mitral clip center, but for people who don't do many cases or not familiar, it's very important to show that what you did with the plus knob and anterior guide talk to optimize the trajectory, like you see here. It's very nice graph. You can see that right there.
And right now we check the orientation again. And we do the grip down the first time.
Yeah, just one small comment here. It's very important, as you shown here, that you lower the gripper slowly. I think sometimes people are very nervous and drop the grippers very quick. And the imager may not be able to save the image, the recording of the dropping the gripper. So you might not know how much you insert. So when we teach our trainees, we tell them to drop it slowly so the imager can save the image like you have done here. Very nice.
Thank you. Usually we will tell the echo doctors we will grip down and he will prepare to record this action because he will measure the length of the grip down, the leaflet.
That's exactly right. Yeah, thank you for pointing that out to the audience.
And the first grip down, and we are not sure, we are not so satisfied with the grasping, and we check the tissue bridge, we are not satisfied, so we plan to do the second.
Yeah, I think it's a good grasp. I think some people may say you want to optimize the posterior to avoid the SLDA, but it looks like the prolapse posterior P2 is quite long. So sometimes you try to go posterior to get more of the P2. It might not be possible, but it looks like you had a very good grasp already. So in the previous image. But you can get more posterior if you want to reduce the what I call the elbowing effect of the prolapse. So if you grab here, you might still have a little bit of a posterior lift. So if you can get more, you can reduce that. This is what we do in surgery, where we really increase the coaptation plane by reducing the prolapse. So the clip try to do the same thing, but of course you only have a fixed length. So it would be better when we try to do grasping to grasp as much posterior as possible with the prolapse.
Yes, the first try, we did not so sure about the bouncing of the posterior leaflet, and then we tried twice. And also we moved the clip a little bit to the a little bit to lateral, so very close to the prolapsed area. And then we prepared to do the second grip down. Yes, grip down. Yeah. So we are so sure about the bouncing.
Yeah, I agree with you. This is probably a better graph. You can see you all the way to the posterior annulus. So you're getting all the posterior leaflet in there, and you see a nice bounce on both grippers. So yes, that is very important to make sure that you have the leaflet pinned between the gripper and the clip arm rather than the leaflet above the gripper. So we had a case yesterday where it was above and we had to free it up to be able to confirm that the gripper can be dropped successfully. So very nice. And you can see you're closing the clip now.
Yes.
So it's very important, I think, also for the audience to know, and I'm sure you're doing this during the case, that when you are closing, you need to go a little bit more posterior and relieve the tension by advancing the clip a little forward to maintain the insertion. So I see that you're doing that there, but I think the audience needs to know as well, because these movements are subtle, so it's not that easy to appreciate in a case like this.
Now we measured the gradient is about 2.
I have one question. Do you do the invasive hemodynamic monitoring with the G4 because to look at the left atrial pressure change?
Excuse me, we only have the G3 system.
I see.
And also, thank you for your comments. We did measure the LAP. Pre-procedure is about the mean LAP is about 14 milligram.
So that's a good point. So the G3 system, when we used it, we also connect the pressure tracing, and actually you can get some tracing. Sometime it might be dampened, so it might not be reliable, but we actually publish a paper on using G3 on measuring the left atrial pressure. So that is actually possible. So you can try it next time.
Thank you. And now we release the first clip.
So again, I think from a teaching point, since you do not have use fluoro, because it's echo guided, when you release the pin, the imager, the echo imager needs to show you where the pin is being pulled back into the guide to avoid left atrial, any kind of potential injury. So it's very important to do that because in fluoro, if you have fluoro, you can see it very easily. But if you only have echo, it's very important to teach the audience about that.
Yes. Our echo doctors was very familiar with this procedure. So we make sure the full release. And then we advance the second one. And the second one we are thinking of to clip directly to the prolapse area. So we will clip the plagate and the leaflet both inside.
Yeah, I agree with you. I would do the same, and I would clip right next to your existing clip. And in an ideal situation, both clips will be looking exactly parallel to each other. Since you have the good orientation on the first one. And
Here
once you
we
have
are-
G4, I think you'll be even happier with the procedure time and efficiency because it really helps you with the independent grasping, especially in more difficult anatomies.
Yes, there are several Chinese-made clip device similar to the G4. They are on the clinical trial in China.
So here you illustrate this very nicely. For the second clip, at least in our center, we're always going closed, not open, so so that you avoid getting stuck to the leaflet with the gripper arm. So do you do that routinely with the second clip?
So we just according to the explain to make sure the second one do not interfere with the first one. And also the 3D view.
Yeah, 因为第二个 clip 我们通常都是关起来进去一个 left ventricle 啊，那就没有一个 interaction 跟一个 first clip。
Yes. Here we do the orientation.
So one advantage with fluoro is that if you put the second clip and your first clip is good orientation, then we don't use the 3D. We just use the fluoro to make sure no parallax with the first clip and with the second clip. So we just use fluoro to actually go in and enter, and we try to do as close as possible. So that's one difference that you can use with fluoro guided rather than echo guided. But I agree with you that with echo guided only, you need to use the 3D here to confirm the orientation.
Yes, yes. So right now we use this view to make sure the second one is close to the first one, and right now we confirm that the second one aim directly to the prolapsed area. Maybe it seems the second one is not so close to the first one, but it directly to the prolapsed area.
Yeah, you can also use the 2D, like you saw already under bicommissure view, to check the distance between the two clips as well. So that's another method.
Yes. And then we do the second grasping. So here you can figure out clearly the plagid on the posterior leaflet.
Yes.
So here the bouncing is very clearly. Yeah, that's a bouncing. Clearly.
Yeah, it's a very nice bounce. You get good insertion of both leaflets. And looks like you're about to close the clip now.
Yes. And we release the tension. and then we check the color to check the regurgitation.
Yeah, I mean, looks like there's almost no MR.
A little.
But
A
yes,
trace.
maybe just a little bit there, but it's a very
Trace.
broad prolapse. So, I think with G3, this is an excellent result. I think with G4, you can consider using the wider clip to start. And then if you need to, we typically add an XT afterwards. So you increase the width of the coaptation and to reduce the MR even further.
And then we plan to release the clip.
Did you do a gradient measurement here again?
Yes, yes. And these two clip are it looks like stable. Looks like stable.
Yeah, no, it's very stable. I'm just curious how much the gradient increased with the second clip. Probably I would say 3 to 4.
Yeah, we are checking the gradient.
And what
It's
is your
for-
cutoff now? I mean, we know that we want to be less than 6 or 7, but what is the cutoff from so that for the audience that where we will not release the clip if the gradient goes to what number?
So usually 5 for DMR case.
Okay.
That's a cutoff point.
Yeah, same for us for DMR, and there's been literature showing that for DMR needs to be 5 or less, but secondary MR may be a little higher if necessary.
Okay, so it's 3 or 4. Okay,
Yeah.
so we stopped. Yeah. Thank you. And thank you for your comments.
Very nice. Congratulations. 恭喜恭喜.
Beautiful case. All right, so we very nice demonstration, and hopefully next time we'll have a live demonstration from Fuai Hospital also. All want to see in action, and so basically we'll get ready now in about 10 minutes for a case from Mount Sinai, which is a very unique tricuspid valve degeneration with a TMVR using SAPIEN valve. All right, so we'll join in about few minutes. We'll get
Okay,
you.
待会见啊。好，谢谢。
Bye bye.
Good morning from all around the world, and welcome to Structural Heart Life Cases, broadcasting directly from the Mount Sinai Hospital in New York City. I'm Pedro Moreno, I'm an interventional cardiologist, and I will be your moderator from the western part of the world today, because from the eastern part, we have another moderator from China, Professor Pang Xianban. He's a fellow of the American College of Cardiology. He's a member of the Chinese Academy of Science and director of the Structural Heart Disease Center. We'd love to hear from you, so please send us all your questions either through email, to the website, or through YouTube. Remember, you can view all the previous structural heart cases at www.ccclivecases.org. We have a great case for you today, and let me take you to the cath lab at Mount Sinai Hospital.
All right, good morning, Pedro, and of course, Dr. Professor Xiang Ben. We are just there about earlier case, and welcome to all from Mount Sinai Cath Lab for our this structural case session. Myself, Dr. Samin Sharma, Dr. Gilbert Tang, Dr. Kini, Sahil Khera, and our fellow Dr. Supawat and Richard. So we actually have now 4 structural interventional fellows. So program is growing quite a bit, and this is actually the second case which we have done since we started our structural live cases is the tricuspid valve intervention. So we also did last time also the tricuspid valve replacement, TTVR, and similar case, which will be showing it today. So with that note, knowing there will be a lot to show and discuss, we can start our presentation. These are our supporters for the case, and these are all faculty, which I have mentioned, all of us, and Dr. Stem Larakis, he's on the echo side there, and you'll be hearing him quite a bit. And our cardiac anesthesiologist is Dr. Mark Stone, and our moderator from China is Professor Pan Xiangbin, and along with a few other associates are there, and he is the vice president of the Fuhai Hospital. So this patient, we're going to show you valve and valve TTVR with a 26 millimeter Sapien 3 Resilia valve because of the patient age in a high risk patient, because patient has 2+ heart surgeries. So with that note, this is the case. Our number 54 is a 42-year-old patient presented with dyspnea and ascites. And as we know, tricuspid valve disease many times present with, of course, edema and ascites. Patient has a first surgery at age of 17 in 1998. Then has a few complications as shown there, and then had a surgical tricuspid valve replacement with a 27 millimeter epic porcine valve in 2021, yep. And then has a pacemaker, AFib cirrhosis, and esophageal varices. Lot of medications, and as you see, warfarin in most of the cases. With the tricuspid valve, they end up with getting some kind of anticoagulation, TTVR particularly, on, and patient's good medical therapy. Rest of the parameters are shown here, and patient has a echo, which has been done as a TEE. Severe bioprosthetic, tricuspid valve stenosis and regurgitation with the mean tricuspid gradient of 10, and pressure half time 331 millisecond, and effective orifice area of 0.6 centimeter with a severe bilateral atrial enlargement, and ejection fraction is good. So more importantly, we should show the live TE echo in this particular case by Dr. Larakis.
Yes. Yes, good morning. Sorry for this. One minute here. Here. Yeah. Okay, sorry for this. So this is a four-chamber view. As you can see, the LV function is almost normal. As Dr. Sharma said, the RV is like moderate dilated with mild decreased function. Both atria are very dilated. You can see the smoke in the left atrium, and also you can see the interatrial septum bulging to the left because of the high right-sided pressures. As Dr. Sharma said, the patient has metallic mitral prosthesis. As you can see here, the valve is functioning well with minimal normal MR at the hinge points. The mean gradient through the mitral valve is 3 millimeters mercury. This is a 3D image of the mitral valve. You can see the two discs and no significant mitral regurgitation, no PVL. There is smoke in the left atrial appendage, but no clot is seen. This is the pulmonic valve functioning well, no problems. The aortic valve in the middle also functioning well, no stenosis, no regurgitation. And this is now the RVOT inflow view. As you can see, the tricuspid prosthesis, the leaflets are thickened, and in some views appears that they are stuck. This is a 3D image of the prosthesis. As you can see, severe mitral regurgitation and severe stenosis from the turbulent flow. This is a true view image of the same valve. And again, you can appreciate the turbulent inflow and the significant severe mitral regurgitation.
Tricuspid.
Tricuspid regurgitation. And the mean gradient here is 11. And you can see here that the pressures, this is underestimation because of basically equalization of pressure, and we see this all the time, triangular TR, tricuspid TR velocity. These are the two valves side by side, the mitral valve and the tricuspid prosthesis. And this is with color, you can see the severe TR and normal functioning mitral prosthesis. Thank you very much.
So it looks like the tricuspid valve is frozen. But why that is in just few years?
Patient is only 42 now,
Yeah.
so she had surgery in early 40s. We know that with bioprosthetic valve, the younger you are, because the body metabolism, the faster you degenerate. And remember, the tricuspid valve is a low flow state. So these bioprostheses, remember, they're originally designed for the aortic and mitral position, and they extend it to the tricuspid position. So we actually don't know, and this is actually not uncommon. We've seen most of the tricuspid valve reintervention for prosthesis failure are younger patients, like in this patient.
But what is the mechanism? What is the mechanism of failure? It cannot be degeneration.
Pannus, yeah,
okay.
basically, you know, just thickening and these are processed tissue.
Also,
Yeah.
yeah. I think also Pannus.
It's a pannus formation
yeah.
causing the
Pannus formation,
both.
yeah.
You can see the orifice very small, as stem is shown nicely in the echo.
Yeah, the
images.
leaflets look almost like stuck
Yeah,
and
They're
very
stuck.
thick, very thick.
Exactly.
yeah.
Okay. So let's go back to our slide presentation. We continue. This is excellent things we have seen. These are our transesophageal pictures, which are 3D view of the tricuspid valve. Very nice. And then it is our CTA. Gilbert, you want to comment on it?
Yeah, so this is a St. Jude epic porcine valve. You can see that nicely shown there as an example. The fluoroscopic signature, you'll see it later, is not that visible. This is one of the valves that is hardest to deploy. The good thing about this particular case is that you see those very bright dots. Those are called the core knots. And this particular case, because the patient, the surgeon decided rather than tying the knots directly with your fingers, they use the core knot, which increases the fluoroscopic signature of the sewing ring area, so it makes it a little easier to implant. And you can see the right side, that's the sapien-free ultra valve, and now we have residual tissue. And you can see that the valve size on average, mean diameter is 125, area of 470 millimeters square, and a perimeter around 77. So I think it's a nice 26 resilia. We can even add volume to post-dilate to make it better expanded, because you can see the pannus formation. So I think that will hopefully confer a good longevity with this particular device.
Beautiful.
And don't forget leadless pacemaker there.
Yes.
And patient also had a leadless pacemaker we
Be
mentioned there.
careful with the
So basically, this is a
wire.
summary of the case. A severe bioprosthetic tricuspid valve stenosis and regurgitation from malcoaptation and pannus growth, and clearly that going for surgery will be very, very high risk. There is no true STS calculation for the tricuspid.
Correct. Not until just now. They just released the STS calculator for all operation. They just came out. So,
Just came out.
yeah.
Okay. So we just have to update our the STS risk for the tricuspid, which we don't have. But overall, it's a high risk third of surgery, and that's what we are going to plan in this particular case. Okay, Anno, tell us what you have done and where are we now?
So we can go on the fluoro.
Yep.
Exactly. Okay, hold on.
Deep probe up, please.
So yeah, this is a very nice
This
picture.
is the view where I
Very
will
nice.
be able to place the valve. If you see that.
And I'll just comment for those of you not familiar, those the things that's sticking out on the sewing ring of the epic valve, those are the core knots. So you can see those little barb-like structures on fluoro, and that looks like a really nice way to visualize, quote unquote, the sewing ring of the tricuspid prosthesis and also the landing zone.
And those are the white dots we saw on the CAT scan?
Yes, that's correct.
Okay. Now Anu
over
will
the
tell us step by step the strategy so that
Pull back.
Dr.
Right? I
Sharma.
don't survive.
Yes.
Yes.
Hello, Dr. Sharma. So this Sapiens
No, can we go? You want to see only?
device
Yes.
is this device the same as you used in the
No.
mitral valving valve?
Can we go? JVAR.
That's correct. Yes, exactly. Same valve.
JVAR.
Yeah,
It's the
so
same.
yeah, exactly. And as you know, they have even done it in pulmonic
Edgeless.
positions as well.
Right.
So so all four valve position with the Sapien 3 platform is feasible.
Yeah.
So the
Actually-
same valve, same
Yep.
delivery system.
That is correct. Yes.
Little
We
bit pressure.
remember, just like the mitral, we need to flip the commander system upside down because the way the flex works. So it's basically the same as mitral, just you don't have to do a transeptal puncture.
Yep.
And Dr. Kenyan and Dr. Kara will actually show you how we approach this.
So
I
we're
think-
going up with the edgeless.
Yeah.
Okay.
So I think one of the
Let's see.
discussion for
Keep going.
tricuspid is that they used to actually position the stiff wire in the right pulmonary artery because they thought that it might be more, trackable. However, we find that it's very non-coaxial in terms of deployment. So now the practice has changed that we typically would place the stiff wire in the RV apex instead, just like the mitral, the LV apex, to make it more
Pull back.
coaxial
Okay.
to
Okay.
cross into
Wait.
the tricuspid valve and deployment.
Why you took it out?
And
Crossing
you also
wire.
see
On with the
that
multi.
here, we do not use pacing on the right side. So of course, on the left
No, why
side,
should I use
you need to
J-wire
rapid
itself?
pace to deploy the sapien valve in the mitral position. But in tricuspid position, we have not needed to do any kind of pacing to optimize our landing.
So this is the edgeless sheath in the
Edgeless.
RA right now.
Yeah. 3D on. I think J-wire is better. Never give this now.
So
Let
keep
us say
telling us
J-wire.
what are you doing now, what
No,
wire
no,
you
we
are
are
using.
trying to. We should be using the J-wire. I'll change it to the J-wire.
Okay, get me a J-wire.
Okay.
Yeah,
So
usually
we are right. We need a 3D view. Stam.
Yes.
Okay. Echo.
You want echo?
Yeah.
so severely stenotic valves,
You
stiff
zoom in, please. Zoom.
glide wire is good, but for
No, zoom in,
predominantly regurgitant valves, J-wire is better.
Good. You went in?
No. The side.
No, the atrium is very big.
Big.
Can we get to another view?
The
It's a wrong
multi-purpose
view.
catheter through the edgeless?
Yes.
Yes. Same as TMVR except the transeptal.
Now T up there. I
T
think I
probe
don't
up
see it.
stamp.
T up.
Yes, please.
Up.
Yeah. So
See
More?
there?
Yeah. Up. Yeah.
make it point the other way.
So you can see that you can have a nice on-force view of the tricuspid. So you can actually maybe use that gillis to point right at the center to try to cross as well. That's another way to do it rather than an RAO projection.
You're on the other. Totally wrong. See
Keep
that?
coming, Dr. Kinney. Yeah.
Yeah. Okay.
So let me
That's a
ask the
good view.
China team here there. Do you see a lot of prosthetic tissue valve in China for tricuspid, or it's mostly mechanical that you use? Professor Pan?
No, in China, we seldom use the tissue valve in tricuspid. We seldom use.
No, please leave it.
It's all mechanical then. Yeah.
Pull it down.
Yeah, actually, in the surgical literature, there's really no mortality difference whether you use tissue valve or mechanical valve in the tricuspid.
Yeah, that's
The only difference is that with tissue valve, your anticoagulation is based more on mitral rather than tricuspid in terms of iron out target. So it's not higher than what you have for mitral.
Yes.
Mhm.
Why don't you put a multi-purpose ahead?
No, we have.
we have it.
Multi-purpose. Let's try to go multi-purpose through the tricuspid valve.
We are not. The thing is, not able to get the end on.
Stam, can you show us on 3D where we are?
Here. 3D?
Yep.
Here. You are on the side, see?
Side.
On the side, yeah.
Yeah.
Try it on false view. You can just point at the middle.
Oh, there. Yes.
Yeah, that's good.
Yes.
Yep. Yep.
Come down. Almost. Yeah. Can you take the picture? Please? Okay.
now.
Right here?
Come.
Mm-hmm.
Come.
Yep.
No?
The side.
One is a crossing wire.
You can always go for V18. In all these tough cases, go with V18 will
No,
go.
I think we can use.
We have a
just the-
crossing wire.
Yeah. You want on
Or
force view?
V18.
Yeah, go.
On force view, I think on LAO.
Get a V18 wire.
Here.
Yeah.
Just point
You
towards the middle of the
magnify
circle,
this, zoom.
and then you should be able to get it.
No, but
Yeah, put the Gillis right.
Pedro,
in the
you're
middle
saying
circle.
something?
Rotate.
yeah, I think the fluoroscopy is not
right there,
giving
right,
us
right there. Oh, just rotate
the
this.
right approach. The TE, the
No.
three-dimensional is better, huh?
Yeah, otherwise,
For coaxiality.
There you go,
otherwise,
there you go.
otherwise,
There
yes,
you go.
yes, yes.
Yeah,
Good,
like
good,
that.
in,
Good,
in,
good,
in,
got
in.
it. Yes,
Got
yes.
it.
Very good.
Great,
No,
great.
no,
Okay.
no. Arvind.
Yes,
we
yes. Let me see. Dr.
We are, we are.
Okay, good.
Yeah.
We are.
Yeah, yeah, yeah.
Yeah, yeah.
Beautiful.
Now,
you're
in
in.
this
Wait,
process,
wait.
what will
Take
happen
this
to
down.
this leadless pacemaker?
Just,
No,
It can
that's
come
what
out?
we were saying. You have to be very careful.
no, the pacemaker has been sometimes it should be
Yeah, it's been 2
in
years.
already.
2 years.
All
Yeah.
right.
Obviously, we have to be
You
careful
do
with
now.
the stiff
Okay,
wire.
Again. No, leave it, leave it.
So I should,
Okay.
we should put a picture.
So now they have advanced
J
the
wire, let's put a
multi-purpose over the
300,
wire.
no, it's not
It's
300.
300. It's 300. Always
300?
use long. I always use long.
Okay. Now long pigtail.
Get me a long pigtail.
So the other thing that we've learned is that with stenotic tricuspid valve,
Watch the wire.
we used to say try to flow a swan and then the exchange
Good.
it's too floppy. So with a Gillis, you actually have a complete control on
Damien?
steering. And a lot of these right ventricles are very big and different in terms of orientation. So we actually find this to be very helpful in terms of crossing, especially in stenotic tricuspid valve. Because if it's purely regurgitant, I think it'll be easier. You have a big orifice, but you can see how small that opening is, as
the
Stam
wire.
has shown you on the TEE. So it makes it much more challenging.
Okay, what is the next step now?
Now we are
Pigtail.
going to go with the long pigtail and
Okay.
then change it to a safari, right?
Yes.
Okay. Gilbert, can you tell them the view? Why you think on first view helps us?
So this like kind of like the exact what Stam is showing you on echo. It's just the opposite. So with the prosthetic valve, if you have a circle, and in this case, you can show that you just point that Gillis right in the middle. It's like throwing darts. You're waiting for the center, and usually it should work in your favor. And then once you cross, then you can go back to the RAO to make sure your trajectory is good.
Go ahead. Go ahead.
Why RAO did not help us in the beginning?
I think it's just the valve is very
Good point.
stenotic, so you're aiming,
spin it.
and remember these atrium are massive. Look at the echo
Wait,
there,
wait. Let me
right? So
put
the
this
big
down.
atrium, you end up very hard to
Yes.
get to the middle.
Flex on.
And also remember, there's also severe TR, so right atrial pressure is very high. So you're actually fighting against the stenotic and regurgitant valve when you advance the wire. So it's not dissimilar to severe AS. You're going retrograde. That you have a small orifice and then you're fighting against a high velocity jet.
Are we in the
No.
apex of the RV?
Yes.
You were.
No, I'm asking Stam.
Let me see.
Yeah, the apex, the RV is not big. It's actually dilated, but it's actually not big. You can see the on fluoro very well as well.
Floor.
Yeah, I think you are, Dr. Guinea.
Yeah, we are. Because you can see the micra there, right?
Yeah, so the
could
micra is
be.
usually at the apex.
Yeah.
Okay.
So here we have to just be very careful because it's a stiff wire.
Not
Hopefully
stiff
we
enough.
should have enough support.
Wait. Let me come out with the.
Not yet. Okay. Let me remove the pigtail
No,
first.
no,
One
it should
second.
be
Can
together.
you put the full volume, please?
Cannot be.
So the other thing is that in China, you have the different transcatheter
Got wire?
native tricuspid valve replacement. At least
Spin the
my
wire, okay,
understanding
just
is
spin the wire.
most of them still put the stiff wire in the apex. Is that true? Professor Pan and the team?
We prefer the Safari.
Yes.
Good.
But
Yeah.
but you put the wire in the apex, right?
You do.
I'll be
Did you
apex.
suture this?
No, you don't. Because you'll pull it back
Yeah,
to
apex.
No,
get the balloon inside the
It's
valve.
coming out. Hold the.
Let me hold this.
So here, the top of the Safari wire is in the RVOT.
Yes.
No, it's
No.
across the valve. You see the sewing ring is with this view is overlapping with the mechanical valve. But you see the
Valve.
wire is basically going from the IVC, you got wire,
Yes.
right atrium, crossing the valve into the RV apex. It's not RVOT. They used to place the wire in the right pulmonary artery for support, but we no longer do that because it's not as coaxial. And you see once the sapien 3 valve is crossed to the tricuspid position, that is like the mitral that is more coaxial if you place the wire in the RV apex. But of course, you have to be careful in terms of risk of RV injury. That's why we use a safari wire, and you have to be careful about
So the
getting the valve. So
skirt is other way around.
Yeah, so skirt we check, make sure it's opposite, like the mitral is antegrade.
Yeah. Okay. So you're holding the wire.
Yeah, Toro.
And the commander system is upside down.
Good. And let's mag out.
Yes.
Is it upside down?
Yes, it is.
Good.
Yeah. Okay.
And no role
Mag out
for
more.
balloon here, huh? No role
No.
for valvuloplasty here.
It's an open valve.
Yeah.
Beautiful.
Fixed open leaflets.
So we're going to go so
Keep
that you
going
can
again.
see the sheath. Just like the mitral position, we sometimes have to pull back the sheath to be able to mount the valve onto the balloon.
Yep.
Keep going. Good. Keep going.
So Dr. Kinney is taking her time because you don't want to have changed the trajectory with the right ventricle. This is not the left ventricle, it's the right ventricle. So we're very particular about pushing too hard with the wire. And
Keep
she's nicely, you can see that advancing up through the sheath. And then once she's in the
So
position,
now
then she'll pull
I will
back
pull
the
the sheath
sheath
back.
to a little bit more. A little bit more.
Good.
Yeah, good. Okay.
Yeah, let me pull the sheet.
Bring
over.
the
One
sheet
trick
back.
is don't suture these sheets because you
So
have to pull
Pawan,
them
come
back.
here.
Yeah, I don't worry.
Hold,
It's
okay,
okay.
okay, okay.
I
Yeah,
can
hold it.
help you. Good. Okay.
Good.
Let me mag in now.
Gilbert, come on my right side.
Okay. One
Gilbert,
sec.
come on my right
Yeah.
side.
Okay. Yeah, I got
Hold
it.
the
Alright.
sheet. Press. It's bleeding.
Yep.
Push the wire, Gilbert.
Yeah.
Okay.
So I'm gently applying forward tension on the wire, so you maintain that trajectory. While
Okay,
Sahil
good.
lowers the valve, you can see that onto the balloon. Okay, and then now let me center the screen, please. Okay, so I'm just
There's
gonna,
no rush here.
no rush here, exactly.
Go
Good.
ahead. Yeah, go ahead. Go ahead.
Fully flex.
So-
Fully flex.
Yeah, it will. As you approach.
Fully flex.
Yeah.
So I'm just maintaining neutral tension on the wire so you can easily cross. Remember, this is the right side, not the left side.
Perfect. Little more. Little more.
Okay, good.
Okay, good. Let's go to the view now. 1 second, please.
Now, can we just adjust?
Sorry,
Pull
let
the
me-
thing back.
So which view was that? 52?
52, 15.
Okay, so we're going to be very steep, huh?
Yeah.
Okay. Okay, anesthesia team, just beware of the patient on the head, please.
Stam, how
Hold
do
on,
you
hold on. What's
Yeah.
that? Broken
This is it.
connection.
Yes, sir.
how do you see it at the
Actually, very
at the plane of the valve? How do you, see
you
the
see
prosthetic
the
valve?
core knot that I mentioned before? And so if you do a cine, you also see that as well
Yeah,
very nicely. Yeah.
Hold the
yeah.
wire.
It's very
Push the
coaxial.
wire.
Very coaxial.
Yeah, push the
Yeah,
wire.
very
Push the wire.
ventricular. Yeah, that's right.
So everything has to be slow here.
Isn't
okay?
isn't it a little bit too far in? Or
Yeah,
Yeah,
we're going
it's,
to pull
it's
back.
true
We're going to pull
ventricular,
back.
yes. So we hold on 1 second. We go to, yeah, there we go.
that's better.
Yeah.
Yeah.
Okay.
So we can just cine test
Yeah.
because there's
but,
no pacing
don't
here.
do 3D. Show us 2D. Okay.
2D,
3D, 3D is
Okay,
good.
Good. Good.
Looks
So
very nice.
everyone see that how we position here, similar to, and then it's a very slow inflation because obviously we're not pacing.
And is going to obstruct the mitral or disturb physiology
no,
of the
no.
mitral valve at all?
No, it's way far.
Okay. Do a
Ready?
cine. Yeah.
So cine deployment. Huh?
Cine deployment.
Mhm.
Yep.
Everybody is in the good position.
Yeah.
Yeah,
Position.
good position. Yeah, 1 minute. Let me see.
Yeah. Show me 2D so I know I
Yes.
confirm.
2D, Dr. Kinney.
Okay.
Where? Okay.
Yep.
Going very slow.
Okay, ready. Okay, go. Start going. Inflate.
Yeah.
Slow inflation.
Very nice.
Go full.
Cine.
Go.
Full. Yeah.
Excellent. Fantastic.
You have to do one more.
Slowly pull back.
Yep.
Okay.
No, why don't we
Good.
do one more?
Okay, go
Everything
in.
is looking good.
Go in.
The one.
Okay. Going up.
So relay is a very stiff tissue, so
in a
we
little
usually
bit.
do a
Go in a little
bit.
two
Full.
balloon dilatation
Go in. Okay, yeah, good.
to expand it further.
All
Go,
right.
full.
Full.
Full?
Full.
You see it
Nothing
in
left.
the
Yeah.
T2.
Yeah.
Okay.
Yeah.
Should we put
Yeah.
another CC?
Let's see how it looks.
Okay, coming out.
Okay.
Tell us, do we need to put another CC
All
and
right.
inflate?
Let's assess on echo.
Yeah.
Beautiful.
Okay,
So,
coming out.
so one thing is
Beautiful.
important to note here. Even though the measure CT diameter is 25, remember you have penis tissue, you have other things. So that's why you see a waste there.
Yes.
So some people even argue you should fracture these,
Yeah.
right? This is a fracturable valve. But I think for the purpose of this case, we'll not fracture. And we have not done any mitral fracture, but there's some people who have started considering that in terms of risk of mismatch and underexpansion. No, but I think this is a beautiful result of exactly where you wanted to land in this, and you see that it does not require pacing, just a slow inflation.
Mean gradient of 2,
Fantastic.
minimal central MR, no PVL. Actually, the MR left. No
TR.
TR. Sorry, no TR at all. No
Good.
PVL.
Beautiful.
Mean gradient of 2.
Wow. No TR at all.
No
Good.
TR, nothing. No, it went away. It was limping in the
But
beginning,
you
but
think now that there's a valve, we go one more CC and go?
the leaflets got
I mean,
used.
you already nicely flare
have
outward,
flared out
so
nicely
you're just
here.
constrained at the sewing portion of the tricuspid. So I wouldn't necessarily do that.
I think it's a very stable position.
It's a stable
You have
position.
good
It's
flaring on either
right-sided.
sides.
Any comments, Professor Pan and your team?
Yes, this is a very beautiful procedure. So our question is, why not use pacing in the tricuspid position?
Well, it's a right-sided system, so it's low pressure. So the other question is that where do you put your pacing lead?
Yeah.
So the only option would be either left ventricular pacing or
RA.
coronary sinus pacing. So those are the only two options. Of course,
No,
you can
even
also
coronary-
have a program, someone there to program the micro to do rapid pacing. So it's more complicated than necessary. We learned that through lots of tricuspid intervention with replacement, in terms of some of the Vivid registry and others, that the practice now is no pacing is necessary for the right side. And our congenital colleagues do intervention on the right side a lot, and they don't usually do pacing at all.
No, even if you do coronary sinus, it has to go through the
Correct.
temporary.
So
yes.
typically you would have to do it in the right internal right jugular vein access to do pacing on the right side, or left ventricular pacing with a stiff wire on the left side. So again, it adds to the complexity of the procedure. This is, in our mind, probably the simplest, at least from the AV valve intervention that you can do in terms of replacement.
So everyone believes
and-
no need for one more CC?
Think everyone agrees?
And patient is
and
quite
the-
young. If you any
Yes.
gradient,
No,
you
it's
can-
Gradient is 2.
2. Gradient is 2, Dr. Sharma.
No, that's the thing.
No MR,
Yeah.
no TR, no PVL.
then
Perfect.
okay.
Perfect.
If
Then,
the other comment will be if the pacer is going through the tricuspid valve during the deployment of the valve, then the pacer will be in between.
Correct.
Yes,
So
yes,
so
yes,
that's why you
that's
cannot
right.
put anything in.
You cannot
across.
do it. Yeah, exactly.
Okay.
Okay.
Now come out.
Yep.
I mean, if you want, we can do a pullback, but I think I would exchange with JY.
No,
JY
no,
with
no.
the
I'm
pigtail.
only concerned is another CC there because she's a young patient, cannot have anything.
let's add another
anymore.
CC.
Right.
Yeah, I think Dr.
Last.
Kinney's concern is valve deformation because of the waist, which is because of the panis. So we're going to do one more inflation with one more CC.
They will become 27.
So around 27.
Gilbert, you okay?
Yeah. So hold. Let me position the wire. Can you advance, please?
Go ahead. Go ahead. Slow.
So the balloon is not fully deflated. You see that, right? Just make sure it doesn't get
Yes,
catch.
fully deflated.
Yeah, now it is deflated.
Sorry.
Yeah,
sorry.
good, good,
Little more.
good. Okay.
Okay. Okay, going up.
Sinai.
All right. Okay.
Okay. I think we are good now.
Okay, so you saw that
It flares
it is
out.
more expanded, more flared. The waist is
Better.
less than before.
Gradient lower. You want to put a what pigtail?
Pigtail, yeah. Let's do some hemodynamics.
Mr. Gradient, yeah.
Leave it.
You hold a sheath, please.
Yes, yes, I am.
Push the
Oh, wire.
That's
Don't worry.
okay.
Don't worry.
Right there.
You got wire? Yes.
Yep.
All right.
Pigtail is.
So it was a 2 millimeter gradient last time. I mean, it will be very tough to see even less than that, the echo.
Yeah, 2.
Yeah, I mean, in the future, if the valve degenerate, I think this is kind of a bridge to the next surgery. This patient is only 42, so we don't expect this valve to last, 20 years, but maybe hopefully 10 to 15 if we're good. Although the last valve only lasted 3 years,
Yep.
2 years.
3 years
So
only.
we have to be very careful about the follow-up on the echo and function.
Dr. Tang.
Yes.
Yeah. So right now the gradient is 2. So what is the perfect gradient you think in the tricuspid valve, the cutoff point?
Great question. So as you know, in Triluminate trial, we're doing the transcatheter edge repair with TriClip. And so those gradient, we found that as long as 3 or less, that should be fine in terms of at least for the edge. So I would imagine for prosthetic valve will be similar. Stan, what do you think? You're part of the Triluminate trial.
Yeah, around 3 to 4, 3 to 4 at max.
Yeah,
At max.
yeah. Especially remember,
here?
once they exercise, it can increase as well.
This
So
is
we
in
have to
the
be aware,
IDC.
be mindful of that.
That's
So.
okay. Just checking gradient.
Thank you.
And Gilbert, is there any data that is associated with better or worse outcomes regarding procedural, residual or in tricuspid?
Great question. So I think there's still very few patients with elevated gradient after tricuspid intervention, especially repair. So the Triluminate trial did have some patients with a gradient 4 above, and they have, but there are very few of those patients, and it's too early to tell whether they have any adverse events. But certainly, I think from the tricuspid standpoint, obviously lower gradient the better.
You don't see?
Because it's a very dynamic
What
system.
color is the other one?
So that's why I think I agree with Stan that around 3 would be probably the cutoff that I would be able to would tolerate for intervention.
And no values for hemodynamics like RVEDP here.
Sure,
We just do
yeah. I mean, but keep in mind that we only have one single access. We would have to
No,
put
we
an
are-
internal jugular line or some other line to have a measure the right atrial and right ventricular pressure.
Cool, eh?
Of course, you can also still do a right high calf after this if you want to. To interrogate the right heart more further. So, but I'm not sure if we need to in this particular case. The RV function appear normal. It's dilated. The right atrium is massive, as you see on the echo. So again, the right atrial compliance is going to be very, very, very different, from a normal right atrium.
And what is the pulmonary pressure that we are seeing right now?
Well, we don't have a
don't
PA
have- we don't
catheter
have a
in there.
I'm sorry,
Yeah.
RV systolic pressure. I apologize. RV systolic pressure.
Well, let's maybe show. You can
52.
see that here.
You see that?
52. Okay.
This is in the RA.
So we're doing an RARV hemodynamics.
Now, that's a very good question, Dr. Moreno and Professor Pan's team. These patients, you have to make sure the right ventricle is not too sick.
Yeah.
Because if they're very sick, you now have an acute loading of the right ventricle now because you don't have the stenosis anymore of the tricuspid valve. So you have to alert with the anesthesiologist to make sure you don't have an acute RV failure, as you mentioned. So you're absolutely right. This patient has a good right ventricular pressure, but your patient with very low right ventricular systolic pressure, you worry about burnout right ventricle and can actually go into acute RV failure if you intervene in this procedure. So that's something that from a post-op management standpoint is very important in patient with a very sick right ventricle. But great point.
And this,
Can you do fast speed? So about 2 we are getting, no?
Yeah.
16
No.
and 14. 16, you see that?
So you see
13,
some
16, yeah.
right side of pressure measurement here.
16 RV
And
RA
14.
pressure. Huh?
And
It's-
14.
there are signs of heart failure, of right ventricular dysfunction here.
Yes.
But certainly, with the experience of you guys in the OR, having had post-operative massive RV failure, how do you extrapolate these? This is a specific question. Any contraindications to do this procedure in or very high risk for, let's say, RV systolic pressures?
I mean, extreme pulmonary hypertension, Dr. Sharma, Dr. Kinney, any thoughts on this? I mean, I think if you have like an Eisenmenger's kind of adult congenital
Exactly.
situation,
I
that's
don't know if
what we
we get it,
worry
yeah.
about that.
that there is a way to figure this out by the RV to PA coupling,
Yeah.
Yes.
where you evaluate with TAPSI and the PA pressures. You can see, if the if the ventricle can withstand, if the ventricle is too far out, too far worse than what you expect. And in this case, actually, we did not measure, but doesn't look like it because the RV looks functioning well, and the PA pressure that I get now after the new valve is about 25 plus 15, so it's about 40 systolic PA pressure that I get now.
I think it's similar to any tricuspid therapy, RV to PA coupling, and RV systolic pressure that is high is a good sign that you have pulsatility in the RV. So any tricuspid device you do, doesn't matter whether it's TR or Intrepid or any of the other replacement or repair strategies, you need to have RV pulsatility.
Yeah, absolutely. And to Dr. Moreno's point about the operating room, the difference with this is that there's no heart lung machine. So the cardiopulmonary bypass impact on the right ventricle is not trivial, especially if you get to cross clamp the heart. So I think that is what we need to, as a surgeon, we always want to protect the right heart, not just the left heart, because that is what will get you out of the operating room successfully.
Okay, excellent comment.
You're going to remove the sheath. What is the next purpose? And you're going to put a closure device. What are you going to
just one ProGlide and we're done. Yeah.
Do you need a wire or just take it out? So we just take the pigtail from across and then we'll close it. Yeah.
Done. So nothing to micra. It's pretty safe. Done.
Yeah.
Document that, please. Document the micra is okay.
Yeah. TE up, please, Stan.
Sorry? Yeah. You want to pull out the TE?
Yeah, no, just pull it up, just so we can show both valve. We can see nice on force.
Pull the TE up. Okay, now good.
Face.
Yeah.
Here you go.
Two valve, the pacemaker and TE, four things in one.
Okay.
Okay, good. And then take a RAO view for the micra.
And patient has the constrictive pericarditis also. Look at the calcific pericardium.
And then we can show the.
Okay, this way. Yeah. Take another cine. So our EP friends will be okay.
Okay. So you see everyone, all three valves, two valves and the micra again?
Yeah.
Okay, good. Excellent. Okay.
Okay. So now with the procedure, actual procedure done, let's talk about some tricuspid points. We can go back to our slide presentation. Yeah. Any questions now from Pedro or from our Chinese colleagues?
I don't see any
point of view. Okay.
From the audience. We don't have any questions from the audience. No.
Okay.
Dr. Sharma.
Yes.
Hello, Dr. Sharma.
Yep.
Yeah. So I have a question for the anesthesiologist. So during the procedure, so what kind of medicine he used to maintain the hemodynamic stability?
Dr. Stone.
Yeah. What medication are you on, and what's your strategy in terms of managing the right ventricle during these procedures?
Phenylephrine is the answer, huh?
Yep.
In case you get hypotensive, yeah.
Yeah. So so Dr. Stone, our excellent cardiac anesthesiologist, said phenylephrine as a start if the right ventricle is okay, but if it's struggling, we might have nitric oxide. That's also a adjunct. Invasively.
Yep. All right. So just some theoretical discussion on the tricuspid valve. In this year, there have been a lot of publications, and I'm going to talk about this one by one. One is the TriLuminate pivotal randomized clinical trial, Sinai being a main center, and Dr. Adams, one of the PI. He's the PI with Paul Sorja, co-PI, and then Bright study registry, basically TriLuminate in all type of cases with a 30-day outcome. TriLuminate is 1 year outcome. Then the CLASP, so basically another device rather than TriClip. At 1 year, and then the replacement of the valve, the 1 year outcome, and Evoke registry, 2 year outcomes, then TriFlow device for TR, there's another fancy, just presented, one case done, and the concomitant TR for secondary tricuspid regurgitation and MR. So this is actually the very common picture, all we can use the devices at various levels. What has really gone further is cooptation devices and now the transcatheter valve replacement and TTVR. And that's exactly what we did today with this patient. So first is the TriLuminate pivotal trial presented in ACC and published in NEJM. It's a much more addition, I would say improvement on the already existing mitral clip. So TriClip G4 delivery system, and I think in China they said they have only G3. So what is the difference, Gilbert, and G4 and G3?
So G3 has only two sizes. They're the narrower clip you can see on this picture, the XT and the NT. And G4 now is four sizes, but also allows you to independently grasp the leaflets or optimize the repair and customize. And with the tri-clip system, you see the knob has changed as well. So it's not like the MitraClip system. So it makes it easier to steer down and more coaxial to the tricuspid valve.
Okay. Beautiful. So basically, this was the single arm. The registry data were presented of 80 cases and so, but the randomized was about 350 patients to TriClip and medical therapy after very intense eligibility committee evaluation. So we actually present 5 cases, maybe 2 or 3 makes it and others are excluded for various reasons. And clearly it has to be the ability that all the parameters are that investigator feels that they are going to reduce the TR to moderate or less.
Yeah,
right?
for the randomization.
Randomization. And we had the 1 year follow-up, and these are the cases basically overall large, almost everyone is the severe, torrential or massive. So very, and of course comorbid conditions, and these were the primary endpoint. And they basically were composure of death or tricuspid valve surgery, heart failure, hospitalization, and improvement of more than 15 point of KCCQ score. And basically in the device versus control was superior, and others were secondary endpoint, which are shown subsequently. So basically what is shown is that the decrease in the TR severity, as you can see there, in the trace to mild to moderate or severe, the red group, which is on the left side, and in the follow-up at 30 days and then 1 year, you can see the red in the device group significantly disappears. About 10-11% remain the severe, and so other become mild to moderate. And this is the important, this basically what led to the positive endpoint of the trial. And you see there was no difference in the death or surgery and heart failure hospitalization, but KCCQ change more than 15 points was much higher in the tricuspid TriClip group versus the control. And basically overall outcomes were similar. And so also shown that quality of life parameters, that if you're moderate or less versus severe, increase in KCC score actually happens higher if when you started with the more significant the residual tricuspid regurgitation. So I mean, you same basically that you leave more residual tricuspid regurgitation, less will be your improvement and patient's feeling. Other endpoints are very simple, safety profile very good, and they actually have put together all the tricuspid valve trials, and where the triluminate comes in very nicely in terms of 1 year mortality of about 7%. And the rest actually all based on the various subgroups and concomitant baseline risk factors. We have in some of the trials of the tricuspid, there is up to 20 to 50% even mortality. So overall, did very well from all point of view, and of course from quality of life improvement point of view, also very good in the middle, as has been shown. So this basically was that this is the first of the trial, which of the randomized tricuspid trial, which shown quite good in terms of improvement in quality of life. Although a lot of people were concerned that the really quality of life is one, but we need to say some hard data. And hard data basically in these patients is repeat hospitalization, but that was not noted. Gilbert, you want to comment on that important point?
Yeah, I think that this is a 1 year data, so it's early. I think we know that from even surgical literature and medical literature that people don't die of tricuspid disease in 1 year. It's about 2 to 5 years that people start to have a high mortality. So I think we'll see how the 2-year follow-up will be. Hospitalization is interesting. It could be due to multiple factors. This is a heterogeneous patient population. We see it all the time. We see patient MRTL or isolated TL. They're two different patients, but they both got, obviously, the MR being treated enroll in this trial. So we have to do more subgroup analysis.
And very important, because I said that tricuspid people don't die. There were those who were enrolled in this 7% mortality at 1 year. And remember, in the our tower trial, the 1 year mortality 30% or 20% in the intermediate group. Then in your mitral clip, about 17%. So clearly, it's a lower group. And very nice, editorial and actually conclusion of that the tricuspid tier is safe. And so then what about patients? So you take this is the bright the registry where all cases, so not necessarily very strict based on the triluminate, but as the kind of real world data of the tricuspid G4 tier system for multiple centers, including USA and Europe. And same, the latest device was used. All these are high risk patients, severe. And actually look now, the implant success 99%, procedural success 91, device time 76, and total procedure time 96, and number of clips about 2, and various clips here. So Gilbert, you want to comment on this one compared to what we do in our real life versus what was noted in the triluminate?
Well, this is European data, right? Because
Yeah.
in Europe, they have commercially available tri-clip system is CE marked already. So this is the registry from our European colleagues looking at the early experience of the G4 system, a dedicated system in this. And you can see that, just as mitral clip, the procedure is very safe. In experienced hands, these are experienced center, you can see the procedure time is reasonable. And most of the time now, they're using the longer clips and the wider clips because they find a better TR reduction and easier to grasp.
Yep, and great success, close to 100%. And of course, reduction in the TR, this was the 30-year data, very significant, as well as improvement. And see the complications, just a very, very minimal, very low complications of the device. And same, functional class, KCCQ improvement, and so clearly showed that even real world, very safe and effective in treating tricuspid regurgitation. So now if you put together, and this was the editorial by Orman and Masberg of the NEJM of the triluminate, there are 2 other trials going on, which is the TRI-Chi-F and TRI-FR with the various types of regurgitation, will give us the overall data in terms of where the tricuspid clip should settle in. But clearly the first pivotal trial is very positive, and I was told that they are going to go to FDA with the we are part of the triluminate, and now we have a continuous access for the patients who are appropriate. They're getting the clip, no longer randomization while waiting for the FDA panel. What is the timeline, Gilbert, in the FDA panel?
I think probably the commercialization here in FDA approval, hopefully early next year. That's our goal. But the good news is that with our continuing access, we've seen an increase of patients with TR referring to our program, and they are all very happy about the results that they get, with the TR reduction and actually symptomatic improvement. I think that is a win for the patients.
Beautiful. So then, second is the Kodali presented and then published in a 1-year outcome of the Pascal device, the similar way, Pascal and Pascal ACE implant. The data are similar to what we have, the same. It's the edge-to-edge repair. And overall, of course, it just depends on your experience. And I know the Pascal 2 and CLASP, the trial 2D, has compared both devices in the mitral side, but tricuspid also similar type of data, that it's just with the gradual experience, although we do not have at Sinai. Is it clinically approved for right side? No.
No. Not yet. It's
not
still
nothing.
Completed
So
trial.
yeah, and so probably the trials is still ongoing for the tricuspid valve point of view. Good success rate and overall same. The timing and the complication rates are very small, as shown here, using the 30-day and 1-year outcome. So class TR. So now we got 2 of them. And clearly more important is heart failure hospitalization was significantly reduced in these patients, but they're only controlled to themselves. So this is the Pascal system. So therefore another device. So clearly we got TriClip. Now we got the Pascal for treating this tricuspid regurgitation. Then we go to the next level, the replacing the tricuspid valve with the complete replacement with the Evoke system. and for initial 30-day data were originally presented, and now the 1-year data were presented. The TR severity, as you can see here, remains mild, or maybe the TR grade 2, or in 96% of cases it's less than 2. So just to say that whatever is done with replacing the valve, it benefit continues, and same way the functional class improvement. So this is the central figure. You can see here, this is the 27 patients. Initial data were presented first, and now they have the 1-year data overall, but works quite well, and the reduce the TR significantly over 96%, and benefit continues with a very low mortality of about 7% hospitalization and so. So these are basically the overall various aspect of improvement. And key is that there is almost no mortality. So only because patients are sick, they have, and all the RV dimensions and functions all changes. So clearly Evoke is the device. The trials have been still ongoing for that, and basically where it will fall in, we need to see. Maybe we'll take another 1 to 1.5 years. Now there is another center, I mean from Europe, they have the data on 38 patients up to 2 years. Overall very nice, same way what were the data for 30 days and 1 year. From United States, basically there was one migration, 3 patients required pacemaker, so 38 of 3 is like 6-7%, and then 9 cases of halt. So it's not uncommon. All of these patients are on anticoagulation. The 2 valve thrombosis and halt is very common. I mean, 9 cases of 38 will really make a very high incidence of halt in these cases. Gilbert, you want to comment on, despite almost everybody is on some kind of anticoagulation?
Yeah, I think that is going to be potential Achilles heel of TTVL. Sahil, you want to comment about, the whole replacement? You're the PI for the trick valve, right? So in Sinai. So
I think this is a very important point that Dr. Sharma made here, that thrombosis is a real problem in valve replacement, and with the clipping you have an issue with leads or malcoaptation. So a lot of these patients who are referred for TR are candidates for neither of these procedures, whether it's replacement or for clipping. So we do have trick valve here, which is IVC, SVC, dedicated valve system. Again, right now it's a palliative procedure, if you will, who are not candidates for either of these strategies. But again, we have to think about pre-existing leads, risk of thrombosis when we are thinking about valve replacement, and severe malcoaptation gaps, and leads impingement in clipping. So there's going to be a patient who fits none of these devices, and that's why it's so hard to select patients in these cases and where to fit them in.
So another device, so this one which we had to continue to follow, and TTVR, Evoke, very promising, and so they put it together as an editorial, that effective device and low heart failure and so. Now there's a new device, they actually presented one case, TriFlow, and try to understand a little more, is the tricuspid valve flow optimizer, and patients with the tricuspid regurgitation, some like a tripod, putting percutaneously, and they say basically decreasing the restriction of the leaflet coaptation and decreasing the regurgitation from 5+ to maybe 3+. Gilbert, any comment on this? Because there's very little data available.
Yeah,
There's
I
one
think,
case.
Edwards used to have the spacer that tried to kind of, improve the TR by doing that, but this is actually has a little valve that actually maintains the flow through the orifice. So I have to see, I think, the question is whether the anchor stability and with time, so we have to, look at longer follow-up in terms of the durability.
So they did a one case, and now they say we're starting the trial. So other question very commonly comes, this is the last of my presentation, is that patients have, many of them, severe MR and severe TR. And of course, it's already secondary, TR is the most common mechanism. So should both be combined? Should you do a concomitant, the tier of the mitral as well as the tricuspid? And they actually have a very nice algorithm, so where you should use isolated tier and where you should do a concomitant strategy. Basically, if you have a pre and post capillary pulmonary hypertension, that is the case you basically do the tier. And or if you just have a only isolated even capillary high wedge pressure, basically, that those cases you do a tier and wait. and how they're going to improve. But if there's no pulmonary hypertension, those cases may require the tricuspid clip also at the same time, and the RVPA coupling. Those are cases will require the simultaneous the tricuspid clip. So, what is our experience here of the mitral clip and tricuspid?
Well, I mean, we don't do them concomitantly.
Yeah,
We do them staged because we have triluminate as an option. So we typically, per the study protocol, we do the mitral first. Then we wait 60 days to repeat the studies. And then if they qualify, then we just put them into triluminate. That's been our strategy. And also remember, tricuspid is not that straightforward in terms of a clipping standpoint. There's imaging issue. There's a device issue in terms of steering. So these procedures can be long. So our mitral clip cases are very short, 10 to 20 minutes, depending on number of clips. Yesterday we did one with only 7 minutes with 2 clips. So we like to do mitral first and then plan for the tricuspid.
Okay, Anu, you want to comment on the quickness of doing the mitral clip versus tricuspid clip?
I think the imaging is the key. With the mitral, we have the imaging is way better. So our tricuspid you cannot, and sometimes we have used even ice. So that is why tricuspid probably takes a longer time. Always there is a learning curve. So I think we are still in that learning phase. That is why it's taking a longer time. But I think like discussion has happened and Gilbert mentioned, always do the tricuspid and wait and see. And most often, mitral first, wait and see how the tricuspid will respond rather than do at the same time. Yes.
So in, let's say, last 3 years, how many cases we had done mitral first and then we brought the patient back for tri-clip?
I would say about close to 10 now.
10.
Yeah, that's just suddenly actually an increase. Last 2 weeks we have like 4 or 5 of them. We did the mitral, and all of them have severe TR that is going to be screened for triluminate.
And that actually, they have the whole algorithm using the pulmonary hypertension, whether you combine, and what has shown, and this is a very important slide, that these cases, if you do only isolated MR, you see the mortality is 33%, but if you do concomitant both MR and TR, whether it's same sitting or stage, really goes down to half. So this is interesting that once you do MR and TR case, after MR, don't leave the patient cold, means follow it, and if continues the TR, then you should take care of that. So this basically they have pro and con, and the whole algorithm very nicely. It basically goes down to the same, that if you have coupling or you have isolated post-capillary pulmonary hypertension, that means high wedge pressure, yes, those cases you do both combined versus TR only. So nice algorithm for that. So just completed now. We are reaching to the time. Tri-clip device is safe and effective treatment strategy in selected patients with TR with significant improvement of KCCQ and quality of life indicator, but no impact on MACE or repeat hospitalization. Then Pascal device has also been valuable, addition to tricuspid as repair and good data up to 1 to 2 years. Then TTVR using Evoke system shows excellent short and long-term results with a reduction in TR, but with some low incidence of device thrombosis despite use of oral anticoagulation. And many patients with severe MR also have severe TR, usually secondary, and may require combined TR procedure, especially in patients with low pulmonary pressures and RBPA coupling. This combined or stage double valve TR strategy associated with improved survival compared to MTR alone. So there is now 3 questions. Following statements are correct for 1 year outcomes of the triluminate pivotal trial of severe TR, except higher quality of life improvement in the tri-clip, similar MACE rates between both groups, similar mortality rates between both groups, and reduced heart failure readmission in the tri-clip group versus control. We know that there was no decrease heart failure admission, so it's wrong. Then following statements are true regarding the Evoke TTVR trial, except significant reduction in TR up to 1 year, significant reduction in heart failure class up to 1 year, residual TR is more than 2 grade at 1 year in 25 to 30% of cases, and halt is noted in about 10 to 15% of patients. Clearly, we know the residual MR is like 10% more than 2 in after the Evoke. And then lastly, that following statement is false about the concomitant tricuspid valve TR versus mitral valve TR. Done concomitantly, combined TR has improved survival, usually indicated combined pre and post capillary pulmonary hypertension, useful in cases with RVPA coupling, and can be staged after MTR is isolated post capillary pulmonary hypertension after seeing the response. Clearly, that if this patient is they're not good where there is pre and post capillary pulmonary hypertension. With that note, we complete our presentation for today. And if any questions from our Chinese colleague, and Pedro, you make the conclusion.
Very good. Well, thank you so much for joining us from all over the world. Thank you for the heart team, for the structural team at Cath Lab at Mount Sinai. And thank you for Professor Sean Bean for being co-moderator since from China. Remember, this case will be available this afternoon in ccclifecases.org. Most importantly, we do our Heart Lives cases every other month, the second Tuesday of the month. So today is August. We're going to do it in October 10 at 9 in the morning. Thank you very much.
We know that Mount Sinai Hospital is one of the most famous hospitals in cardiovascular field in US and in global. And Professor Tang have lots of contributions and also well known in global. And also today we also have the Professor Samin Sharma together with us. Now I can have Professor Tang to moderate the first case from our center.
Thank you very much for the invitation. Hello, everyone. On behalf of Dr. Sharma, who will join shortly, and myself, we welcome this collaboration. 你们好，谢谢你们的邀请。OK，现在我们做一个第一个Professor Mao Chen 的 case。Please go ahead. 谢谢。
Yeah, we will ask the Dr. Zhao have the introduce of the case. This case is done was done today morning in China. In our center. So I think this is very challenging case to us. So we have so many questions want to discuss with Professor Sharma and Professor Tang. Okay, go ahead, Dr. Zhao. 小赵，你没有打开静音，你没有打开静音。
Good evening to our Chinese colleagues and experts, and good morning to Dr. Tang and Dr. Sharma. So I will present the case on behalf of the team. And the patient is a 72-year-old male, and he presented with progressively worsened exertional dyspnea, a cough and sputum for 7 years history, and he has COPD, and at this time he had acute decompensation of chronic heart failure and cardiogenic shock. He had PCI 8 years ago, but at the current hospitalization, coronary angiogram demonstrated no significant abnormality, and there is no restenosis in the prior stent. And the treatment currently include antibiotics, and he was intubated shortly after admission. And the medications include vasoconstrictors, diuretics, and SGLT2. And this is the EKG of this patient, which showed sinus rhythm and LBBB morphology of the QRS. And it is interesting in this patient in terms of the severity of mitral regurgitation was dynamic. On admission, it was at the end of September. The echo graded the mitral regurgitation as 3 to 4 plus. But shortly after this, the patient's condition get worsened, and he was intubated. And after intubation, the echocardiographer evaluated the mitral regurgitation. It decreased to 1 plus to mild, and this remained after the intubation. And on October the 8th, our echocardiographer reevaluated the severity of mitral regurgitation, it was still 1 to 2 plus. And we have some parameters, including LV and diastolic diameter of 72 millimeters, small left atrium, which was 28 millimeters, and LVEF was only 27%. And after medical treatment for this patient, his condition got better, and he was extubated after October the 8th. I think the date here is running spell. But after the extubation, the mitral regurgitation was 3 plus, and VC was 7 millimeters. And the patient's condition also get worsened, which was in line with the worsening of the mitral regurgitation. And at this time, the LA diameter, which was remeasured at 35 by 51 millimeters, and LVEF was still around 30%. And because the baseline echo was performed at another hospital, so we do not have the original images, and the recorded images showed us that this patient had really severe mitral regurgitation before the intubation, and there was significant enlargement of the left ventricle and relatively small left and right atrium. And as we have just mentioned, after intubation, this patient's mitral regurgitation was reduced to mild. And this was confirmed by an reevaluation several days afterwards. On October the 8th, the echo also showed only mild to moderate mitral regurgitation. But we can also note that at this time, the left atrium was even smaller than at baseline. And these images are also obtained when the patient was under intubation. And indeed, the mitral regurgitation was not severe. However, after the extubation, we can see that the mitral regurgitation get worsened to moderate to severe again, and along with the worsening of the patient's clinical condition. And these images are also obtained after extubation. So it's 3 to 4 plus mitral regurgitation. So the heart team considered this patient's condition was highly related to the dynamic mitral regurgitation in this patient. So I think our echocardiographer, Dr. Liang, has some further images which was obtained today, just shortly before the procedure, and she will present those images to the experts and audiences.
好的，那我来 share 我的屏幕。 Okay, dear colleagues and experts, let me show you the TTE performed just before the procedure. And at that time, the patient was not incubated. And the TE images show, oh, I'm sorry. This is not the first one. These TTE images are got before the patient was incubated. So we can see here that the patient has a very large left ventricle and mildly dilated left atrium. And we can see that the LV systolic function is severely impaired with ejection fraction around 20%. And there is mild pericardial effusion. And from these images, we can see that here, the mitral regurgitation is moderate to severe. And during that time, we noticed that there is a relationship between the patient's respiration and the MR severity. During expiration, we noticed that after the patient was incubated, we performed the TEE echo for the patient. And also, we can see a very large left ventricle with impaired systolic function. And the MR severity was improved. TTE image just before the incubation. And there is no morphological abnormality was observed in the mitral valve leaflet, but we can see that the posterior leaflet was tethered and was restricted during systole. So there is more coaptation of the anterior and posterior mitral leaflet. The MR severity seems to be moderate during this time. And we also observed the interatrium septum and the length between the mitral annulus and the roof of the left atrium is only 32 millimeter. That's a very short IAS. So in summary, for this patient, we think that the MR severity, MR etiology is the secondary MR, and it's Carpentier type 3B. The MR severity varies from 1+ to 4+, so it's a dynamic MR. And the mitral valve area is 5.22 centimeters square, while the mean transmitral gradient is 5. And the leaflet length at the A3 and P3 region is 27 and 11 millimeter respectively. That's all.
Okay.
Thank you.
So I think this patient is very interesting. And hi, Professor Sharma.
Yes, I'm sorry for a little late here, but I am following this very interesting case, very dynamic, very sick patient, but looks like going into the right direction now after intubation.
Sure. So I think this the first question because the patients have the two, to me, I think the two possible options of the intervention procedure. The first is just because the dynamic mitral regurgitation, and so the TO is possible therapy to this patient, and also the patient has the wide QRS LBBB morphology shape, so and combined with the reduced injection fraction, so maybe CRTD is another option or choice. But just because the situation of the patient is so worse, so my first question: do you think this kind of patients we should do TO for these patients just because the dynamic, the motion model, this style of the dynamic mitral regurgitation? How about your idea? Do you will you do the TO for these patients or not?
Yeah. So I think maybe Gilbert can also comment. We have some few cases of like that in last few years, and there have been data now that fulminant heart failure, cardiogenic shock, and the patient on balloon pump. Actually, our patient was even balloon pump. We did and same, so dynamic. MR is so dynamic, and did the clip, and patient did very well. Gilbert, you want to comment?
Yeah, no, thank you. It's a very complex case that you outlined here. You know, the goal of these tier cases are to bridge to decision and recovery. That's the goal, to get the patient to survive the hospitalization. Because even though they can be surgical candidates, you know, you want to kind of bail them out. So in your case, the patient is intubated. Obviously, we need to get them extubated and go home. In our case, as Dr. Sharma mentioned, patients on a mechanical support. We need to wean the mechanical support, and we discussed our surgical colleagues all together as a heart team and said this is the best and safest way to reduce the MR. And then afterwards, you can then decide whether to do CRTD, you know, GDMT and other things. But the first is to save the patient's life. That's the goal.
So I think our choice is right, as you have said. Maybe this is save life of these patients, but the another very challenging to these patients is the technique scale, because you can find the symptom is very short because the left atrium and the right atrium are very small, and even we have the salient resuscitation, the height about 3 centimeters, just 3 centimeters. So I think this is another difficult to these patients is technique, difficulty. So just because we think these patients no other choice, so we want to try in this morning in our center. So I think Dr. Zhao can show us the recording case.
Okay, so these are the recordings of the procedure which just occurred this morning. And Dr. Feng is currently doing atrial septal puncture. And actually, the echocardiography has already measured the height, and it was only 25 millimeters.
Yeah, we want to puncture higher, but it's female. So finally, we just have the puncture height, only 2.5 centimeter. But the regurgitation looked in the close to the 3 zone. So to some extent, I think it's very challenging. That's all. Go ahead.
So then Dr. Chen started to insert the CDS I think any comments are welcome when we are replaying the recordings. And if you think, okay.
Yeah, no. So what clip did you decide to use?
You know, in China, we just the Airbot XTR and NTR, no G4. So we were today's patients were using the XTR.
XTR, this one?
Yeah. Just
yeah, I
because
agree with XTR. I think the challenge that you mentioned is the transeptal height. So I think if you plan to do XTR here, we would in our center we would do advanced steering right away. So we would not just do the M knob and posterior guide torque because you know that you will not have enough height. You would do the the advanced steering with the P or A knob steer.
Yeah. So I think the key point is how to get at the P3 and the S3, and so like you have mentioned, we should balance the CDS and the vertices and steering sleeve, and to maybe we should borrow some kind of height, just using the volume, the left tribe. I asked to a professor to one question. In your center, we always see the central height is so low. Maybe these patients we can call maybe the red patients are yellow patients. That means the tail is not very good for these patients. And in your center, do you think the puncture height is the the mandatory indication for TIL to these patients?
Yeah, no, it's a very challenging situation because if you don't get enough height, you will not be able to do the procedure. So yeah, no, I mean this by default is not a green case because patient is in shock. You have a small atrium, it's most likely more QM dynamic MR as you mentioned. So by default, it's already a complex case. Even though the grasping anatomy is not that difficult in terms of leaflet length, and you have excellent imaging. So I think it's very low risk, very safe to try. And sometimes we try even, for example, in patients with small valve area, right, or higher gradient, like so with mitral annular calcification, or MAC. So sometimes we tell the patient that we may not be able to deploy the clip if the gradient is too high, even though we have a good MR reduction. But because mitral clip is such a safe procedure, I think it's very reasonable if the patient has no other options to consider that.
Yeah.
So it looks like you're already on the valve. You already done the 3D steering.
Yeah. To these patients, we make the decision to try the TIL just because the patients is the etiology of the mitral regurgitation is functional mitral regurgitation, not the degenerative mitral regurgitation. If this it's a patient's prolapse mitral valve, I think it cannot do, because it's very difficult to grasp.
Yeah, so it's nice to see that despite you have, well below even 3 centimeters of height, you're able to steer with advanced steering, which I noticed you did, to get to the medial aspect of the valve without, with actually still some height left, and still actually very nice trajectory to the pathology, because you don't have an aorta hugger, which would make it even more challenging if that happens. So very nicely done. You can see that here. You can actually now check the orientation, and then go ahead and see where the jet is and grasp and go into the ventricle. Very nice. And like your procedure here was very important to show fluoroscopy, we use a lot of fluoroscopy as well for our procedure to make it more efficient. And we published this before, and we put this into the Sky MitraClip ebook to show the orientation of the clip. You can use fluoro to make sure you do not spin or rotate when you go into the ventricle, which can happen, especially in a dynamic situation. So
I think this is a tricks and tips is personal to us, because we are familiar with the DSA imaging, so can help us to make sure the the trajectory in the same orientation.
And correct, and you can also see that you did not have a medial or lateral dive, because you have the fluoroscopic lever to check as well, in addition to echo. So it's a nice complementary way. And at our center, our imager can also see the fluoro as well, so they can see where the probe position is and also the clip position, so we can work on a procedure very quickly.
So when we do the clasp to these patients, we meet some difficulty just because they cordy, like but I think that not this the position is good, so we will move.
Yeah, the difficulty with these cases, as you know, is the heart rate. You need to have a slow heart rate to grasp more easily, but these patients are in shock, they are sick, so the anesthesia colleague cannot reduce the heart rate for you to grasp, because otherwise the patient may crash. So it's very
maybe we just we just try to control the the volume and the rhythm of the breath, just to make
Yes, that's right. So yeah, absolutely correct. That's a great teaching point, that you can drop the tidal volume. You can also stop the breathing for a moment to do the grasp. Worst case scenario, you can see we can give a little bit of short acting beta blocker just for the grasping, but without G4, this is an extremely challenging case.
Yeah. So like this patients, just because the tensor of the posterior leaflets, it's to some extent, I think it's difficult to hold the leaflets into the arm and grasp the clipper. A little bit difficult. So I always hope we can have the G4, because the independent grasp can help us very much. And but do you, in your sense, when you use the G4, you will how many patients you will using the independent grasp?
So number one, I think we use it to optimize more than independent grasping. But in a very big flail or gaps between the anterior and posterior leaflet, let's say in secondary MR, we would often get the anterior leaflet first, and then bring the clip delivery system further into the ventricle, and then close the clip a little bit, and then hook the posterior leaflet to grasp the posterior leaflet because they're often shorter. And so you want to grasp the entire leaflet, including almost to the annulus. So that's we have done that as well, but we try not to do the independent grasping because with the motion of the heart and the respiration, you can end up grasping the wrong spot on the opposite side, and then you can twist the valve and have a jet. So we try to do no independent simultaneous grasping whenever we can. Only if we cannot or we need to optimize. But when we do optimize, we do it we do the posterior guide talk first, raise the and then bring the clip up to make sure the leaflets is good and better, and then raise the grippers and drop it again quickly. So we don't wait a long time for the heart to have that motion to shift your coaptation. If independent grasping, the same thing. We would get ready for the first grasp for the anterior leaflet usually. Then we drop the gripper and quickly go to the opposite side, again, to avoid this shift in respiratory motion and also the heart motion because of the corkscrew.
Yeah, it's very important teaching point.
Yeah, so very nice here. You can see the leaflets are on, the anterior leaflets on. So typically what we would do is you can close the clip a little bit and then you can then hook the posterior leaflet. Sometimes we even use an intentional aorta hugger. So what that means is that because the posterior leaflet is short, so we'd actually go a minus knot to create almost like an aorta hugger so that you can what we call a hook the posterior leaflet more easily. Especially with G3, because G3 you cannot independently grasp, so you need to make sure both leaflets are inserted before you can drop the grippers, and that is a potential nice way to handle this kind of difficult situation.
Yeah, in that to this particular patients where we do the intentional hugging and to make sure the potent magnets can be grasped very good.小赵，我觉得可以快一点啊，因为这个像就是到后面，因为这个主要是这中间的过程。
I think the engineer is currently controlling the speed. I will ask him to speed it up.
Okay. But to this particular case, I think it's challenging to hold the posterior leaflets into the M because it's a little bit of curve. So
yeah, you're right. So you need to make sure that you don't curl. So here, what we would typically do is to close the clip a little bit to cup it.
Yeah.
So you close the clip and then you bring the clip up slowly. So the anterior leaflet stays on, and then you keep the posterior leaflet not curl as you mentioned. I think the clip orientation is good already. So again, because of the time, we try to not take too long to grasp these anatomy. We try to go in, like you said, close the clip a little bit, then pull up slowly, because the heart rate is very fast, so you can actually rotate the clip. It's actually not that easy to handle this situation, and then you just try to get a grasp as quickly as possible. If you need to optimize, so we have learned to use G3, that if you need to optimize, you can always, once you grab, you can stay the grippers down, open the clip a little bit, and then you can do the rotation and then raise both grippers and drop again. So that's a small trick that we learned with G3, which we have adopted with G4. But certainly it's doable. But you have to position your clip optimally to raise before you raise the grippers and drop again if you want to optimize your grasp without losing the opposite leaflet. Yeah, so now as you can see, it's very nice. You can see you closing the clip, right? You close the clip a bit, it cups it, and it kind of prevents the leaflet from falling out. And now your posterior leaflet, both leaflets are on, then you can now, yeah. So now I would, drop the grippers here.
We just want to make sure the position, the orientation is good. We do the grasp because we don't want to injure the leaflets.
Yeah. And also remember, this is a rescue case. So even if you go down to 5+ to 2+, it's okay. The patient will live. So you don't have to be perfect. And you only have G3. So you want to just grasp safely, good insertion to avoid SLDA, and do your check tissue bridge gradient. You can even check pulmonary vein flow. We actually, even with G3, we published this paper before. You can connect the the flush port, to the pressure tracing. You can actually do that. You don't need G4 to do that. It's not as good. Sometimes it's dampened, but it's still possible. So sometimes when we publish this paper, we have used it to even diagnose mitral stenosis. So for example, if you reduce the MR, but your V wave went up, that means you have stenosis. You cannot deploy the clip. But even if the gradient may be a little high, if you reduce the MR, the V wave is maintained and it's lower, that means you can deploy the clip safely because hemodynamically you reduce the LA pressure. So it's actually a very nice way to determine decision making whether you can deploy the clip or not. And so we've done that. We published that already. So it's even with G3 you have that ability. So I would encourage you to consider that in the future as well.
So after the clasp of the clip and the regurgitation reduced to maybe mild or trace. So I think the result from the regurgitation volume is okay, but we do the immersion gradient like you have said, but the gradient, the chest mitral gradients maybe the mean gradient 8 millimeter mercury. So we do the measurement of the two parts of the orifice, and I think the total size of the orifice about 2.5. So even the choice mitral gradient is a little bit high. We do the final decision to release the clip.
Remember, your heart rate is fast, right? You are in a very dynamic state. So I would not really care about the gradient. And even though, the patient is only 72, if you have to do surgery later, you can still do surgery as an option, let's say with stenosis. You just want to get the patient out of shock and MR, and then you can manage the rest medically. So I would not really believe in this gradient. You can always, after now, the patient is extubated, then you can have guideline-directed medical therapy. You can even consider, as you mentioned, CRTD to further, better synchronize the heart to reduce the heart rate. So you have a lot more options to manage this patient after you get this initial problem.
Yeah.
So really
I
nice
totally
result.
agree with you.
Very nice result.
Yeah.
The key is going to be
Wait,
diurese this patient aggressively to make sure the patient doesn't, have a heart to stretch and dilate. So have to be very aggressively make sure the patient is volume negative. So, but great case.
Yeah. Thank you.
Fantastic case. And hopefully, and we wish the patient recover well.
Yeah, we hope so.
Now, let me ask you, did you think about balloon pump also or no? For acute
blue
situation,
pumping?
yeah, intra-aortic balloon pump. I know a couple of cases in this situation we have done the balloon pump, but I just wanted to hear from your
But
point.
just after the kill, I think the blood pressure a little bit better. So and recover very quickly. So we don't use the balloon pumping to this particular patient.
Okay. All right, but very good. Listen, very tough, complex case, superb. I know many times to show it live, that was originally plan was, would have been a little truncated, with a time point of view, but you took your time and did a beautiful case. Gilbert, you put a last word and then we conclude and then we'll be ready for our case in next 10 minutes.
Yeah, I think you're going to be very happy with the G4 system once you have it. We had it for more than a year now, and this is an extremely challenging case. So congratulations for excellent imaging, excellent work, advanced steering, and in this complex situation. So best wishes on the patient, and I think the patient will do very well.
Beautiful.
Yeah, 恭喜你们啊！
谢谢。
Okay, we'll see you soon. I'm going to get ready for our portion of the case. Okay.
Okay.
Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Mount Sinai Hospital in New York City. My name is Pedro Moreno. I'm an interventional cardiologist and I will be your moderator today. We would love to welcome our Chinese moderators for this case, Professor Cheng Mao and Professor Feng Yang. We'd love to hear from you, so please send us your questions right from the website or from YouTube. Remember, you can view all our previous structural life cases at ccclifecases.org. We have a great case today, so let me take you to the cath lab at Mount Sinai Hospital for the life case.
All right. Good morning, Pedro and our Chinese colleagues. They showed actually very interesting high-risk case of tear. A patient was in almost shock, intubated, and so. And hopefully, we'll kind of duplicate same excellent results which they got. And of course, viewer our CCC live structural cases. And today, on a strong demand, we have shown various kinds of tower, and now we are going to show the mitral clip, basically tear, in this particular patient. And the faculty here with me, Dr. Keeney on my left side, Dr. Gilbert Tang is our surgical director, structural director, and Dr. Sahil Khera is our structural director interventionalist at Sinai. And then we have two fellows, Rajiv and Supawat. So they all do a lot of work, and of course rest of the staff inside. On the echo is the Dr. Larakas, and on anesthesia is Dr. Jill. With that note, we are all set, and of course many faces familiar you'll see, and we start our presentation. Interesting case in the sense I made all, and I just put Dr. Chen Mao, but I know the additional faculty. And with that note, case today M tier in high risk patient with primary MR, secondary to flail and prolapse P2. This is the patient with a case number of 55. Patient is 61-year-old, dyspnea, and has a disability to walk. And lastly, because of polio or some some issues
Morbid
had been
obesity.
also Jehovah's Witness. You know, Jehovah's Witness means for those who do not know, that patient cannot get blood transfusion. And multiple risk factors are shown there. Good medical therapy, and patient has been on intolerant to few of them, and had a severe anteriorly directed mitral regurgitation from the flail and prolapse P2 with ERO of 0.4 millimeter square and EF of more than 55% and mild LV enlargement and mild TR. So with that, this is the crux of the case. Basically, severely directed anterior directed mitral regurgitation, which is recorded, and we actually can show even the current one. This is a trans-esophageal. You can see, and we can ask our expert comments from our echocardiographer, Stem Larakis.
Yes,
this is the mid-esophageal view.
Yes, good morning. Good morning from New York. I have with me our imaging fellow, Julia, and also our sonographer, Hafiz. So, well, real life, yeah. So basically, 4-chamber view, normal LV function, normal RV function. You can see here, this is long axis view of the mitral valve. You can appreciate the flail posterior mitral leaflet. This is the measurements of the leaflets. The anterior leaflet is 2.2 and the posterior leaflet is 1.4. This is the centric anterior jet from the flail posterior leaflet, P2 scallop. This is a 3D image. Okay. You can see the aorta in the top, the posterior leaflet in the back, and the flail leaflet, the flail P2 scallop. Significant broad jet of mitral regurgitation. This is the true view. You can appreciate the flail P2 scallop. This is the glass image where you can see the flail P2 scallop even better, and the white jet of mitral regurgitation. The ERO by 3D is 0.52, severe, no doubt severe mitral regurgitation. The area of the valve is 6.5 centimeters square, good for mitral clip, 1 or 2 clips, as will be discussed. The gradient is 2 millimeters mercury. The pulmonary veins, this is the left upper pulmonary vein, is blended, systolic blended. You can see the appendage in the middle, clean appendage. And this is the right upper pulmonary vein, again blended, systolic blending of the flow. And this is a deep gastric view showing no pericardial effusion to start with. Thank you very much.
Beautiful. So this is live shown, and we go back to the slides. And I just want to emphasize once again on the points. These all have you shown, and more we show it while the procedure being done. And 3D images on this particular case, ERO and leaflet lengthwise. Any concern, Anu and Gilbert, in terms of leaflet length to grasp? Posterior leaflet is 10, anterior leaflet length is about 26 millimeter.
There should be no concern. Actually, should be easier to go.
Yeah, I think this will be an ideal case for a XTW. The question is that is it a 1-clip, 2-clip strategy that you saw earlier? I think it's a big valve, broad prolapse. I think right now the strategy is going to be 2 clips to also to stabilize the repair. 1 XTW to start and then a 1 XT to follow. That's our strategy.
And Sahil, you want to comment on the transeptal, this technique of the safe cross?
Sure. Yeah. No, Dr. Kinney is going to discuss step by step how to do the safe cross. It's basically a balloon-tipped catheter making transeptal really safe. Instead of a needle or a dilator-directed catheter, you have a balloon on top, just like a Swan-Ganz, engages the septum, and then you can cross through it. Very reproducible, very safe. So we really like this device.
Beautiful. Okay. So now comment on the mitral clip G4, which is available here, and we know that our Chinese colleagues said G4 is not available in China. So in this particular case, that is the plan to.
Yeah, so G4, as you see, has 4 different sizes and lengths as well. So basically, there's 2 different widths. W is the wider portion, but if you look at it, the picture, the wider portion is actually at the leaflet area, not up in the top. So that's a little bit a unique design. And then the length, obviously, we know they have two different lengths here. So our strategy at Mount Sinai has usually, if the leaflet is long enough and you're not going to pucker the valve, then we typically use the longer clip. And we like to use the longer and wider clip to start, or the end. So the W is our workhorse clip, and you can see, I'm sure Dr. Sharma might show that later on, the expand G4 data. That's also been the case.
Very good. So therefore, this patient is, clearly with the degenerative mitral regurg is only done patients who are high risk, not necessarily inoperable, which used to be in the past, but high risk. And this patient is high risk because Jehovah's Witness from the blood transfusion patient cannot take. She cannot take. And second is obesity. So both those factors, we have a heart team discussion, and they felt that if we can do a good job of reducing mitral regurgitation to 1+ or less, we should go ahead. And there was a discussion with our echocardiographer, and all the interventionists happened, and they were very confident that we'll be able to do a successful TEER procedure with a very small residual mitral regurgitation, and that is why this patient is on the table. Now, we know that Jehovah's Witness, they can sometimes get the surgery also. Although many centers are notable to do the Jehovah's Witness surgery, Sinai is one of them, and basically require giving the Epocret, epogens and quite a bit to bring the hemoglobin to more than 13. Sometimes it's very difficult, but because of some knowing that if there is an alternate solution and can be done safely, and that is what we decided in this particular case to go for TEER despite the severe primary MR and the low risk of STS. This is not because of the high STS risk, it's just because of the clinical condition of the patient. I think obesity still could have been, but the Jehovah's Witness is a very big factor. With that note, we are ready to show, Anu, your show now. Tell us what the plan and what you are going to do.
So here we have the safe cross that we are going to use to do the transeptal, if you can focus, right? This is just to flush the central lumen, and some dye that will be ready for the balloon, small balloon that is at the tip. This will be the connection to the energy, which is the RF energy. The wire is already there. So just simple movements. If you see here, so this is to a little bit, flexion, which is we can to get into the septum. But more important, I think, we have to do is when you are going there, you will go clock to get into the posterior, or this would be to any kind of anterior movements. So right now what we'll do is inflate, right? Go up, the deflated one will go up there. Good. You'll see.
Could you explain, please? Explain.
All the way. This is exactly like you use with any other wire. The typical steps where you have to go all the way to SVC and come down. We don't have to do all those steps.
You follow, please follow.
And we will see in the fluoro, injecting some dye, just a little bit. Yes.
That's good.
Balloon flotation. So we will do is take out the wire, and then we will have our
the needle, please, let's focus.
The workhorse stiff wire, which is a safari.
Safari wire. We're going to go with the safari wire and have it ready, that once we get the transeptal, we'll just advance the safari into the left atrium. All the way. Okay, just leave it there. So I'm going to just get into the septum with a little flex. That's it. And just like any other movement, right, I will go posterior.
Full, please, full.
So can we show echo, please?
Clock,
live echo.
I'm clocking to go.
Yeah, please show echo and as well, and yeah, and floral. Free. We need free screen, please.
We see that. Maybe I put a little bit more flex. No.
I will just go.
Pull down. Come down a little bit. I'm coming down. I think it looks good.
Stem.
Yes.
You can see that radiographic balloon there, very visible on echocardiography.
It's not showing the whole thing.
Now, Professor Chen and Dr. Wang Dr. Feng,
Yeah, Max.
is the safe cross available in China yet?
No.
They said
Not
it already?
yet.
Not yet. Okay.
Okay, put explain, please.
Okay, it looks good there. Gilbert,
A little posterior.
more posterior.
Yeah. You're mid.
I was posterior, then I came little anterior. So I'm clocking more to go posterior.
Mm-hmm. Yeah.
Micro movements.
Very good. Very good. Very nice.
Okay, okay. Right there.
Fluoro. So that's the only time we take the dilator out once you've reached your destination.
Should we give the energy here?
No,
Let's measure.
A little superior.
I think we are good.
So what we do typically, just for the people who are not familiar with TEER, the next view, as you see here, is the aortic valve short axis to see how posterior we are relative to the tenting.
Can you explain that, please?
So we need to look at that, and we usually do explain now. So we can see that it's not quite tenting; it's a little bit skiving there. I think you can see.
Not tenting, yeah.
Yeah. So maybe we need to adjust that a little bit. Go back to the bicaval, I think.
Bicaval. Explain, please. Explain.
So come down a little bit.
Yeah.
Come down.
Follow that. Follow.
Yes, it's quite
More posterior
It's
now.
quite posterior, and I think
No.
it's also superior.
Okay, now.
Yeah, a little bit more inferior. A little bit more inferior.
Inferior now?
Yes,
Yeah.
please, yeah.
Okay, there.
No, a little bit more.
I think we were in a very good position earlier. No?
There you
Good.
go.
So you see that, right?
That's better.
I think that's better,
it's
yeah.
a bit
I think
more
that's better.
posterior.
A little bit more posterior now. Yeah.
You go more posterior?
So you're mid and mid.
Yeah.
Just go a little posterior.
I think
Okay.
Yeah,
should be okay there.
a little bit more maybe.
Little bit more. Little bit.
Yeah, they're
Good,
perfect.
Good.
Oh,
Stay there.
So again.
Let's go out with the
superior
dilator
again.
pressure.
oh, it
superior
slipped.
again,
Hold
see?
on, it slipped.
It
It
slept.
slipped.
It slept to superior again.
Okay, good.
Stay there.
Yeah, that's
stay
good.
There, stay
Yeah,
there,
that's-
stay there.
Yeah, I think that you can tent there. A little superior though, huh?
Superior again. Yeah.
It's a little
Slips down.
superior. Can we bring it down or? Yep. Yep, there you go. There you go.
Okay.
So can you show us the tent, please, Stan?
Yeah,
Not the
it's-
balloon? Yep, there we go.
Okay, go.
Can you follow? Can you follow, John? Yeah. Follow the needle. Yeah.
We are more posterior.
I think posterior were okay. Posterior
Yeah.
were okay.
Just
A
watch
little
it
bit more
doesn't
inferior
slip.
if possible.
So the other thing is we can flex the
Yeah,
device a
yeah,
little
I'm
bit to
flexing a
engage,
little
yeah.
bit so it will
Engage better.
engage the septum better.
You follow, please. Yeah.
Your
Follow John,
dilator's
follow.
already out though, so you might need to.
No, follow the needle. The needle.
Mm-hmm.
What do you think, Stam?
No, it's
Advance the
a little bit
dilator.
superior. You know, it's has to come a little bit more inferior. Little bit.
I come inferior, then again we say it's low.
Yeah, very
That's
good.
actually not bad.
Okay,
yeah.
good.
Advance the dilator a bit more.
It's not tenting though. It's not tenting.
Cine that, please. Yeah. Uh-huh.
It's not tenting. Yeah. It's, explain
So
that.
Gilbert, tell us about an ideal transeptal for mitral clip.
Let's do this first, then we talk.
Yeah.
Right, let's
Oh,
finish it.
watch your IV pole, please.
Yeah.
Okay, can we?
Cine again for a minute.
Yeah.
Sine?
It's,
Sine?
you can go a little bit upper.
Uh-huh.
That's very posterior. Huh?
Stam, Joanne, what do you think? Too posterior?
Yeah, to posterior. Yeah.
Okay.
Now,
Yeah, a little better.
Okay,
Yeah.
can
Let me
we
go
just,
let me go by cable to see what's happening.
that's actually not bad.
Okay, please can you
It's a bit
Do that?
superior
Yeah.
though.
Yeah, that's
It's very superior.
that's better. That's better. I think. Can you put the needle, please? The needle. Yeah, the needle.
It's a bit superior, no?
Yeah, it's still superior. If we can come a little bit posterior wise, it's good. If we can come a little bit more inferior.
There you go.
Yeah, would be great. There.
Right there.
There.
That's actually not bad. Yeah.
And then now you just need to
Can we just
clock a little bit and you're there. Yeah.
Yeah, you can come a little bit posterior. Little bit.
Yeah, that's
there. It was there.
Perfect.
Yeah.
Yeah.
Okay. A touch more a little bit. Yeah.
Let's go.
I think.
Go,
I
go,
think
go.
we should do there.
Okay, we are going. Go.
Okay, we are crossed.
Okay, deflate the balloon.
And after that, you'll
Though,
tell
no.
advantage of this versus Baylis, which we have been using all the time.
So Baylis, the difference is that the you go from the SCC to come down.
Yeah.
Here you actually start at the atrial cavity. So for the early trainees who are not experienced, that can sometimes risk injuring the SVC, and you sometimes have this windshield effect because it's pre-curve.
Yeah.
This is not a pre-curve, and this is a steerable system, so it's very different that way. So you have more control, especially with TMVR, right? We've done some TMVR cases now, Dr. Sharma,
Yes.
and every millimeter counts because it's a very big device.
Yeah.
For TIER, at least you can do advanced steering, you have other options. But with TMVR, with placement, it's going to be a challenging. I think, did you...
But Gilbert,
Very good.
yeah.
one thing I find is the big difference,
Yeah.
I know this is safe,
Yeah, go ahead.
the balloon. Anchoring to the septum
It's
is not harder compared to
Yeah,
our
you have
Baylis.
to- you have to
In
engage.
Baylis, the needle anchors the
Because
septum
it's
better.
pre-curve. Because
Yeah.
it's pre-curve.
No.
So that's the difference. But you
Also-
can pre-curve this as well.
No, even
but-
if you pre-curve, you
Yeah.
have to remember it's a big balloon.
The
and
balloon
then-
will
yeah.
always slide on the
Slide
septum.
on the
So
septum.
the key
So
here
that-
we learn now is to not to over-inflate the balloon tip. Just enough. So
No, even then,
This way.
just the
I know,
concept.
what about anticoagulation now? Is done?
Yeah, so
we
ACT is
gave
well over
usual,
300.
we gave about 2000, and now as we are talking, as
Yeah.
soon as we are done with the transeptal,
Yeah.
our anesthesia colleague
Stan,
will
can you
give the
show us
full
the height
dose.
from the wire? Were you able to measure the height?
Yeah,
Just
that's
for
what I'm trying to
our
do.
Chinese colleagues here
That's what
to
I'm trying
show.
to do, yeah.
So we only
Can you
give
please-
about
please,
2 to 3000 for the transeptal, then give the full anticoagulation.
So, Dr. Chen and Dr. Fang, any question about this? I mean, you saw the demonstration. This is another new device.
4.3, 4.5.
Okay, great. Thank you.
Yesterday
I
also we
think
had this trouble.
This particular device is safe and effective to transseptal puncture, and I think the pre-curved guide wire can pass very safe to get through the septa and very quick.
This
because whole thing-
puncture wire is very useful.
Pull the wire.
As you saw, they took their time because we know that the whole case in these TMVR and the mitral clip is where the puncture is. Not a correct puncture may take your 1 hour, but puncture rightly done can complete the case within 10 minutes.
Show us,
We'll show you
we're
our data.
coming up with a guide.
Good. Thanks, Tam.
Sorry. Yeah,
Explain.
Explain, please. Yeah. Explain, please. Yeah.
Yep. So you can see the dilator is across, and just make sure the guy is across as well. So what Dr. Cooney is doing is the kind of corkscrew the guy slowly in there and gently. If there's any resistance, you go back and then you
No need for
basically...
fluoro, just show my hand movement. Oh,
Yeah, no, you
okay.
need both,
You need the
both.
fluoro.
All three,
Okay,
all
that's
three.
fine.
So yeah, and then you can see it's a bit of tenting, so you try to go the different trajectory. In some difficult cases, you would even actually do like a what I call a corkscrew maneuver to do 360. A lot of tenting.
We can
there.
change the camera to the ceiling camera then?
Still tending.
Yeah.
Yes,
We're
yes.
showing it now, hands.
Just stay there with just gentle movement. Not beyond the balloon.
So when you're engaging the septum, you go plus or minus here, Gilbert. What do you prefer?
Yeah, so
Or do you change that?
So when you go minus, you straighten out the catheter, so a little bit more pushability. So that's our preference.
That's
So right
what
now,
we
I think
did
it's
mine.
neutral.
Yeah, I'm neutral.
So you can
You want
most
me
people
to go
recommend
little?
and use neutral, but you have this bit
pull
more
back and
pushability, and then
Okay.
you can.
Okay, come back. Okay.
Yeah, so that's always
So
a
you
good
can
technique.
try that.
Yeah.
As an alternative. But the key is you don't push aggressively.
Yes.
Because the two things that can happen, one, you can tear the septum, which is a big problem, and number two is that you can actually injure the posterior wall because you're too aggressive, even with a stiff wire. So it's very important to take your time here. In fact, when we teach our fellows, this is one of the critical steps. You know, the rest of steering and grasping, we can,
Should we
they're
change it
relatively
to
straightforward.
balloon dilation?
But
Try once more.
No.
but yeah, no, but you can definitely need to be very careful about this movement. Let's bring it
Still
back.
tending.
Yes, yes, we know. Damien, balloon.
Just slow corkscrewing movements.
Septum does not look that thick. Or you
But
think
it's
you're just
elastic.
at the junction?
It's elastic.
Elastic septum.
Why don't we do the balloon?
Try now.
That's where we were before. Wire.
Yeah, wire's okay. Wire's okay.
No, we did. Guide back, we came back. You're saying we're coming back and then going in again? The wire may flip out.
No.
How often we had to do a balloon valvuloplasty or balloon dilatation
Of
of
the
the septum?
septotomy. I mean,
before
about
advancing?
30%.
30%. One in three
30% we do every. I think I would take this out and do the balloon.
Yeah.
Don't get aggressive.
So yeah, let's try to do the
Yeah,
balloon
balloon.
here. I agree. It's a very elastic septum, Gilbert.
Gilbert, out.
Yeah.
Come.
Okay.
Get the sheath ready.
18 French
Yeah.
cook.
Get me the sheath ready.
You need the sheath, why don't we do without? It'll
Need
bleed.
the sheath. Want to try once more while we're waiting?
Putting the blood.
What happened?
Here.
Okay,
Yeah,
now
popped
we
in.
went through.
Good. So that helps a little bit of
Stabilizer,
corkscrew,
please, and
Advanced.
the mat, please. So we have a lot of guy across, which is okay, as long as you have a wire, right? And then so you can always bring it back. Short axis, please. Explain. So just like what we
The
do,
guide.
the dilator comes back
Dilator.
first to make sure you can see that the
Where is the guide?
The-
Can
the
you show
guide?
the-
stem. Can you show us the guide, please?
Yes.
Stamp guide, please. Thank you.
It's
Okay,
quite
good.
it's quite a lot of guide.
Quite a lot of
Yeah.
guide.
Okay. And then so we could
So
add
the
wire.
dilator comes out first and then we take out the wire and you see
then you
here,
can see.
syringe, yes.
Okay, Dr. Spahn. Okay, so so Professor Chen, you can see here, this is what we do with the pressure line, and you can do the same with the G-free system. So we do that, and then we flush. Go ahead. To
So
clear the
there's-
fluid, and then we actually,
Clear all the blood from the
yep, and then once we do that,
introducing area.
so that we can see the blue, and then we stop, and then let's see what the left atrial pressure tracing is.
Show the pressure tracing.
So after this, I put the clip.
Zero.
You follow the clip, okay?
I know.
Yep.
Please. I will pull him in.
We're
Okay.
pulling the guide back.
Yep.
Lot of
Okay,
guide.
so what's the pressure? Can we let the
Re-zero
audience
it.
know? It's 23 and 35. Okay, can you give two more down?
Can you see the pressure?
2,000
let
of
us
hep-
see the pressure, yeah.
1 second.
Show the hemodynamics, please. Yeah.
Put
Yeah,
the,
now
what
it's
you should
okay.
do is put the hemodynamic in a small,
No, they
in the
can't do
side.
it.
Yeah, on the top of the echo.
Okay, good. Okay, good.
Okay, we're going because they need fluoro also.
Yeah, you need fluoro and
We are doing blue to
yeah,
blue.
you can take the hemodynamics off now.
Now all four of them are there.
Four of them. Good.
Yes, yes,
Excellent.
that's what
That's
we said.
fantastic.
That's
Okay.
why I said small
All right, Stam, our clip
picture
is
in-
coming out.
Yes, sir. Yes, sir.
So what you do is you come out as you're coming out, first thing,
Yeah, so follow you.
gentle, and then you straddle.
Follow the clip,
You're
please.
straddling here, looks good. Straddling is
Good.
done,
Okay, let's back
right?
in.
And the first movement will be, we'll
the
go
clip, yeah.
medial,
For the clip, yeah.
posterior.
Mhm.
So I'm doing the M knob.
Follow the clip, please, yeah.
Yeah.
Follow,
Just
follow,
make
follow.
sure we are clearing the Comodine ridge.
Yeah, coming down. Follow, please, follow.
Keep adjusting your straddling,
Posterior. Follow the clip, please, yeah.
going up posterior. So right hand on the M knob, left hand on the guide to go posterior.
Yeah, yeah. Can you do tip, please?
Okay, bicommissural explain
Yeah,
now.
yeah. 65.
Okay, watch your IV pole. Make sure IV
please,
pole and
explain,
stuff are
please,
all
explain,
cleared
please, explain.
on the anesthesia side, please.
So
Yeah.
come a little anterior there.
Yeah.
Just tad bit.
You increase the gain a little
We'll
bit.
straighten the clip out.
Yeah.
Yeah, we're coming anterior.
Oh, beautiful, beautiful.
I'm going to add a little plus just to get
Okay, please on the top of the clip,
trajectory.
please. On the top of the clip.
Better. Okay.
Follow the clip, please.
Okay, let's get a proper bicommissural view, and then we can show the audience how that's done.
Okay,
So-
please explain.
Okay.
Explain. The posterior.
I added a little plus.
You can see
Yeah.
these elastic septums. You can have a
Want
little
to
bit of
open?
septal fatigue from the get-go.
Yes.
Yeah.
It drags down and your clip is
Want to
somehow
open
in
the
the
clip?
valve.
Can you show us the more atrium? Is that possible to show us the trajectory of the clip on the bicommissural view, please? We don't need so much apex. We need more atrium.
Explain, please. Yeah.
And it's a little rotated, right? You see that? So you have to be very mindful of that rotation. So what we can do at this point, since it's already on the clip, then we can raise grippers. Now this is different from G3, right? This is, we have to unlock and then we open and we have to actually check the grippers to see which is which. So there's a tactile thing on one of the grippers, and then you say tactile coming down, and you can see it's posterior, right?
Posterior, yes.
Okay. And then
Posterior.
you have down non-tactile coming down.
Anterior.
You can see it's anterior.
Yeah.
Okay, so now what we would do is go 3D.
This is for independent grasping if we need
Yeah.
to optimize.
Correct.
No, higher, yeah.
Okay, we need space in it down in the leg of the
Please,
IV pole, please.
I need some space here.
So this independent grasping is only available in
Can you take this
G4.
out, please? Yeah. Man.
So if you see the hemodynamics, your V waves have gone up. That's because the
We're on top of the
clip
Take
is
it away, please.
engaging
Take it away.
We're on top
the
of
valve
it.
leaflets.
Take it away, please. No, take it away. Take it away. It's okay. No, take away the thing. Yeah.
Okay, good.
Take away the thing. It's okay. The radiation is good. Let's do this case. Okay, please. Let's forward to explain.
Yeah, we can go
3D,
3D
please.
now, Stam. Yeah,
3D.
thank you.
30, please. Turn around. Turn.
So when we teach
Yeah.
our fellows how to do this, we
Yeah.
boil it down to very basic views because we don't want them when they're in practice. They might work with other different images of different skills.
Turn around a little bit more.
So the key for the 3D
Right on
on
the
force
top,
here
right on
is
the top,
to
please.
have a 10 and 2
No, clap.
orientation,
Clap,
right, in terms of commissure. So you can see it's a little bit rotated.
I'm
And
going
so we
to
do counterclock.
Counterclock here. So very simple, like a
No.
face of
they
the
can't
clock.
block the clip.
So I'm going to do counterclock to go to 10 and 2.
No, so
Hold
be
on.
12 and 6 there.
12, 6, hold on.
Little bit more counterclock.
Yes.
Yeah, beautiful. That's great. That's
Inside
great.
the
On the
valve,
Good,
flare
good.
leaflet. On the flare scallop. Yeah.
Okay.
Okay.
Take some parallax off.
Take that, please. Take that.
Can you drop the gain to show us, please, in
Yeah.
terms of the on force?
I think we're more posterior. Huh?
Okay.
Little bit anterior. And you have a medial dive there.
Okay.
I'm more posterior. I'm
2D?
going a little bit
No, not Jack. You have to show us a nice 3D, please. Because I think we're too much counterclock now. right? Can you show us a really nice on false? Yeah, I think that's better.
Can we go down now?
Please explain, please. Explain.
You're already in the valve.
Okay, 3D, please.
Oh, we're on the valve already.
Yeah,
Make it smaller.
that's what I've been saying. You have a lot of septal fatigue, so that's
Make
why
it
it's
smaller,
falling
yeah.
into the.
Okay, can do 3D now?
Yeah.
3D zoom. 3D zoom, please. Yeah.
We're underneath the valve already because there's not.
Okay.
We have some septal
Okay, go
fatigue
there.
from the
Yeah.
being very elastic.
Okay, turn a little bit to do the zoom, yeah. No. They're under the valve now.
Okay, let's.
Okay.
Okay, let's.
How does it look to you, Stan?
Yeah, it looks in good position, bro. Good position.
12 and 6?
Yeah, 12 and 6.
You
yes.
happy?
Yes.
Okay.
Okay.
All right,
2D,
so,
please. 2D.
2D. And let's take
Okay,
the parallax
explain,
out
please.
to make sure. Okay. We're a little bit, we're anterior is on, so but we're a little lateral. Huh?
Mm.
We want to go in and go a little bit more.
Okay.
Yep, we're free now. So we go a little bit more medial. Yep.
Okay, please follow the clip, please. Yeah.
I'm going a little posterior.
Okay, you have both leaflets?
Yes.
You have both. You have both.
Yeah.
I'm pulling back,
Yeah, and
little
come
posterior.
up. Come all the
Both
way
the
up.
leaflets are in.
Yeah, all the way up. All the way up.
I'm pulling back.
Good job.
Taking,
Pulling back.
taking both.
Yep.
Yes.
Yeah, take it,
drop
take it,
both.
Got them.
Okay.
Take it.
And now what we'll do is to close a little bit first, then you lock. Close completely. I'm going
Give
to
back a little bit, yeah.
give back a little bit
Mm-hmm.
to
Go a little
remove some
posterior forward.
tension.
Mm-hmm.
I'm going in a little bit into the ventricle. Yes.
I think
Good.
we lose some posterior.
Okay.
That's okay. Yeah. That's a,
Good.
Okay.
Okay.
On the clip, please. On the clip.
I
He's
think-
saying is you want to show some color or no?
Yeah. Yeah. Let's put some color, please.
Wow.
Nothing. Make it smaller. Make it bigger, please.
Looks good. Huh?
I think maybe optimize posterior here.
Yeah, you need to optimize posterior. Yeah.
Maybe. Let's see. I don't see the V-way come down though. Let's see. Stan, can we get the look at the whole valve for the biconventional view, please? Okay, take your time. Let's just look at the entire valve so that we can see both medial and lateral. Right now, your medial is not fully in view. Yeah, that's better. That's much better, right? Okay, so let's show that and to our audience
let's put
here.
color, please.
Now we
Let's
can do explain.
Explain, please. Explain. On the clip, please. Yes. Okay.
Okay, so
on the
I
clip,
think
on the clip, please. On the clip. Yes.
so. I think we need to optimize the posterior, number one, and number two. Let's show some color now for our
put
audience.
some
We can
color,
see the
please.
entire.
On the
Actually,
clip.
better than expected.
Yeah. On the clip now. Make it. Yeah.
So we don't check gradient here. It's very
No, no.
important. There's no need. It's
Yeah.
a big valve. So here, what we would do, we would optimize here. Okay.
Yeah.
So the steps to optimize as follows. So Dr. Keeney is going to get the device ready, and then I'm going to basically unlock the clip. We leave the grippers down. You don't leave the grippers up. Okay. So we're going to open, and all she's going to do is just going to swing posterior. So go posterior guide torque to get more posterior. Focus on the
lift up the
posterior
gripper.
arm, please.
Posterior.
Yes. I'm
So
going
Dr.
posterior.
Keeney is now doing
And,
posterior.
same, this movement has to be
Very, very
tiny,
small, very small.
movements.
Okay, you see that now?
Yes.
So posterior is tactile, right? Okay. All right, so I'm going to raise now. So she's going to go more posterior.
Good.
Go more
Okay.
posterior,
Okay.
please.
I did.
All the way to
Okay,
the
good.
end.
You have
Okay,
it
I'm
all.
going to drop now.
Yeah, you have it all. You have it all.
You have everything.
And
All the
again,
leaflets.
see that? Just that motion. You can see the nice bounce.
Yeah. Yeah.
And then I'm going to lock early. And then we're going to close very slowly. And she's going to give back tension
Or torque posterior.
while I try to.
Yeah, careful. You don't
Yeah.
do that much.
Fun a little bit.
Yeah. Okay.
But I
all right.
think MR
So
reduction is
we
very
didn't-
good.
Didn't see that much.
Right, Stam?
Yes. Very good. Yeah. It's
And one
It's gone.
clip should be okay.
It's gone. It's gone. Not.
Yeah.
Nothing. Minimal.
But like you said, can you see the valve rather than more LV? Shows the valve
Yeah.
better.
Yeah, let's do a 3D to see. Again, do a good biconventional view, please. You can take the time.
Fun.
It looks so fun. I agree with you.
Okay. Explain, please, dear.
So the only thing that we don't like is that there's a little rotated the
Okay.
clip on the
Okay,
floor
we'll do 3D, please. 3D.
because it should not have because we took the parallax already. So let's see how the 3D
Okay.
looks.
That's too big. But anyway, take the 3D, please. Okay, take it around.
So if you have a little rotation, once it looks okay right now,
It might
once you
get
release
worse,
the
so you
clip,
have to be
Okay.
perfectly sure.
it tends to leak
Okay,
more
increase the
once
gain
you
of the
release the
3D,
clip.
yeah,
So
the leaflets.
I think we're a little rotated here.
Yes. Can you tell the aorta a little bit more? The aorta a little bit on the center.
So it's,
little
it's
bit more,
10
little
and
bit more,
2.
please.
Yeah,
Yes, yes,
perfect.
yes.
Okay.
Take that, please. Take that and put some color now. Put some color, please. Nothing.
Beautiful.
Nothing.
So are you sure the orientation is okay?
Yeah, amigo. It's perfect. Can you
Yeah.
take the color off? Okay, take the.
Professor Chen and your colleagues, what do you
the gate
think?
down, the gate down, the gate down, the 3D gain, the 3D gain down. Yeah,
Can Professor Chen hear us?
yeah.
Yeah, I think
What do you
this
think?
is very exciting result. And my question is, like you have said, in the first, you want to maybe one or two clip strategy. If you want intentional two clips strategy and bailout two clip strategy, do you have some different about the strategy? The position, the first position of the clip, the first clip.
Yeah, very good question. So go back to the bicameral views, Sam,
Here,
please,
here,
to
here,
show
yeah.
our audience.
Yeah, take the color
So
off,
what we
please.
would have
Yeah.
done here, we would start a little
Explain.
bit medial. That was the idea because the broad prolapse, and you can see and flail, but you saw on the 3D earlier the flail is actually gone.
Okay, put
And
some color, put some
so
color.
I think we might be able to get away with one.
move the color,
Remember,
move
when
the
you put
color
a
this way.
second one, there's always a chance to distort
nothing
the
there,
valve. So if you can do the job with one clip, that would be ideal. And I think the Gen 4, G4, allows you to do that now versus G3. I would say if you have G3, this will be a two clip case because you don't have the wider clip. What do you think, Dr. Kinney?
No, I agree with that. Or as soon as we finished the clip, remember that we had
No,
almost negligible MR, but here now we see a little bit MR on the
You want me to
medial side, huh?
Yeah, let's
You
show
want me to show
that.
you guys? You want me to show you? So on the clip.
Yeah,
Yeah,
this is
yes,
on the
yes,
clip.
on the clip.
On the
We want to see, go back.
Nothing through the clip. Okay.
Okay.
Moving medial.
Yes.
Nothing. Trivial.
Okay,
There,
yeah.
see?
trivial.
Yeah,
Moving-
there's no prolapse. But the key that STEM is showing us, there's no prolapse residual on
Moving-
either side.
Yeah, moving lateral. Nothing.
Right? So Professor Chen, I
I
think
want a confirmation on the 3D also.
I think the key
Yes,
is
Dr.
that
Kinney, yes.
if you have residual prolapse or flail pathology, you cannot do one clip. You have to move that to take care of that because that when you release the clip, you're going to have a jet. So I think that is the difference.
Okay, let's see on
I
the
think-
3D.
I think this
Yeah.
is a key message. If we have some residue prolapse, maybe we lead the other
Yeah.
clips.
Right. You would have moved this
Nothing.
more
Dr.
medial
Kinney.
and put a second one lateral. Good.
Nothing. It's
Okay.
Absolutely.
So if everybody agrees, then we are ready to release.
Yeah, great. Amazing. Great. Yeah.
Yeah, let's check the gradient in the pulmonary vein flow just to be
Yes.
sure.
Yes. Yes.
So what we do here, you can start the process, is go to an LAO view. Okay, you want to make sure the clip is not opening up. Okay, so we keep, what we do now here,
Now
if you
can
look
we
at my
show
hand,
the ceiling camera so we can show the release? Yeah.
so the finger goes on the
lateral.
lock lever so it doesn't come back up, and we open to check. You can see on fluoro. Sometimes there's relaxation with the G4 or the XTW, but that's okay. So there's no opening of the clip, so I go one turn pass, and then I go tight again. You don't have to be too tight.
4 and 3.
That's it. Okay. So
Now,
now
other thing is, before
drips up.
release, we always check. I know you mentioned don't check the gradient, but if it was for a secondary MR, we would always check a
4
gradient,
and 3.
right?
Yeah.
4 and
That's
3.
one, and other one is make sure the insertion is very good. Stam, you are happy with the insertion?
Yeah. Yeah. Insertion is all the posterior leaflet is in. The anterior is all in. The gradients are 4 and 3.
Good.
So it's also important to hold your
The
lock
pulmonary
lever here.
The
You check
pulmonary vein
floss.
normalized.
Good.
Normalized.
So you check your floss one here, and then you floss, and then you remove the other one. So you don't need to floss multiple times with G4. So just once, and you go parallel to the handle. This is even more important in tricuspid. Do it slowly. So Professor Chen, I don't know if you have any experience with mitral clip in the tricuspid position, but this is actually very important because the tricuspid leaflets are thinner. So you have to do this step even slower than what I'm doing right now.
Okay.
Okay. So that's done. So now you go back, stay on this LAO view, and you do the same thing again. Open to make sure there's no relaxation, and you do see then that's not. And then so you go back to neutral. And then we typically go back to the RAO view. So we can see the shaft. And then so to take the pin out, this is pretty standard procedure. So we teach all our fellows to do this step first. They have to master this step. You expose the groove and you make sure you see and feel the groove. You want to do that?
Okay, ready, go.
And then so he's going to do 8 turns. We do 9 for good luck. Okay, and then the pin is out.
Yes. Slowly
Just
release
wait for
the
it to
clip.
come out.
So we
Yes.
wait.
Yeah, stand all the way up.
Did you do 8, 9 turns? I think you did.
Done. Good.
Okay, good. So you see very stable.
So we had a lot of M, so undo the M.
And then we bring
Slowly
it back.
and
And
bring
then
it
we
back.
bring the plus. Okay, let's look at MR now. And we'll get
And we can see the hemo, the V
Stan,
waves.
can we look at the MR, please?
Yeah.
Okay,
Very
minimal.
nice.
Right, Stam?
Yeah, minimal.
So
we
you can
can-
see that this is what we expect for tier. Remember, there's always tension in the clip system a little bit. And then afterwards, when you release, it can actually be different. So just keep that in mind. Flush, please. Thank you.
Nothing
Okay,
nothing
good.
medial. As you
Okay,
can see, nothing medial.
Good. Keep flushing. Off, please.
And nothing,
What's the map now?
nothing lateral.
Thank you. So you can see our V wave did come down. So
That one leaflet.
Normalization of the
Yeah.
pulmonary veins. 4 and 3 gradient.
very nice. Stan, can you show the audience the clip again, the position?
Yeah.
Very stable. No residual flail, no residual prolapse on either side. So that's kind of the result that we want. I'm a cardiac surgeon, so if this is a patient or surgical candidate with a primary repair, you want to have mild or better for primary MR. Dr. Keeney, any comment on this case?
No, I think
Sahil, any comment on?
Yeah, so I think there is a tiny bit of MR which looks more than when it was being released, and that's because of the natural laxity of the valve and how the clip sort of sits on it. There's a little bit of it was a little bit rotated, but that's expected. I would not go too crazy about it. I think this is where you say you've done a good job and you walk out of the room. I don't know what you guys think, but
Yeah,
Absolutely.
yes, it's
You can see the orientation is actually good. You can show
Yep.
Stan show the 3D now. It's 12.6 where we started, and actually 12.6 despite you see some floral changes. We don't like to see floral changes, but in this case, I think it was fine. It was just because we optimized my change. But you do when you try to stay in the same floral orientation. That's the key, because echo may not be able to show you otherwise. So I think this is an excellent result for this particular patient. And Professor Chen and Professor Yang, any comment from our Chinese colleagues?
Take that, please. Take that.
and you can see the V waves definitely improved.
Next question: if you, the patients need another clips, which kind of clips you will choose? Which types?
So if let's say this patient come back, we will choose a narrow clip, because what we find with G4 that if you can you change the camera position,
Yes.
please, to face
Come
us,
down, show us full.
the front camera, please, rather than the side camera. So I just want to show a point here. Can we change that, please, the live camera?
I'm gonna go to one for you.
We need
The
that
result
camera. Yeah.
is wonderful.
Yeah. So
Felipe,
okay. Anyway, so I'll try to show you here.
hold on.
So-
Can you show the camera full to
The front,
Dr.
yeah, the
Tang,
front one,
yeah.
please. Yeah,
Yes.
no,
yeah,
no.
you're good. Go there.
Okay, here. So what we're saying is that this is the XTW, which is a wider clip. So the second clip, we now realize that it will be a narrow clip. If you we've done cases from my experience, if you put two wider clip next to each other, there can be sometimes a jet across. So that's not good. So we now actually like to have a fat clip, we call it a fat clip, and then a skinny clip. Next to each other, you can be closer to each other.
Unbelievable.
So that's our strategy. So I think as we do more of these cases, we'll learn more as well. But with G3, what you have is that you can put two clips very close to each other, which is great. So you do rarely have to jet across. But with the W, you have to be careful about that.
Yeah. No, so
Yes.
yeah.
Okay,
Slide
thank
or
you. Thank
timing.
you very much.
Our timing
Okay.
outcomes slide.
So Dr. Sharma,
Clip
you want to
outcome
close
slide.
the session?
Yeah, we have everything. Yeah.
Stan, we're going to bring the guy back to the
Rational,
atrium.
rational.
Yeah, please, yeah.
Of course.
Okay, we're in the right atrium now.
10 minutes.
So make sure you go negative on your guy before you take out to the right atrium.
Okay. All right. So great demonstration and worked out very good with one clip.
Yes.
Wow. This is wider clip.
Congratulations. Very fantastic.
You need this G4
one
clip
wider
is really
clip.
working out very good.
And usually in the primary,
Yeah.
if we get it at the right spot, once one clip is good enough. Yes.
Okay, so let's just show we always try to show the latest in the subject, and that is about the transcatheter mitral valve intervention, data of the 5-year of the COAP trial, and then from the TVT registry, particularly for the DMR, then there are heart failure stages which have come, expand G4 registry which we have shown today, but some data, then COAPT and MITRA Pro scores now for TR outcome, then very important study, that is impact of TR MVR on surgical volume and outcomes, and then of course the new TMVR system which I will show. So 5-year data which all we know, original co-op trial was presented in ACC, published in NEJM, showed the sustained benefit of reduction in heart failure, hospitalization as well as death, and of course rest of the points as you can see here. But what is more interesting is basically if you see the real benefit was in first 2 years, and after that it kind of overlapped. Reason is why. After 2 years, patients were randomized, those who could, I'm not randomized, those who were in the control group crossover. And this basically was the reason that 67 of the 312, because remember 169 has already died by 2 years. So these are the 67 of 312 got the clip, and very interesting, their outcome was similar to our device. So even if you started your clock at 2 years, the outcome was similar to the device in terms of the death or heart failure hospitalization. Very interesting observation. Second, safely, even on the long term, overall safety event just shows you that device specific event is very, very low. The detachment, embolization, all are less than 1%. So this is a very established technique. Second, this is the data presented again in European Society by Raj Makkar of the ACC TVT registry, large number of patients, non-emergent, about 19,000 plus. As you can see, of course, these are the high-risk patients for the degenerative mitral regurg, because right now in United States, degenerative MR like this will be done only after surgeons will write it off that surgery is not a better option for this particular case, and most of them are moderate to severe and severe. Overall outcome in these high-risk patients is still quite good. Mortality of less than 2.7% and readmission 2.6 at 30 days, and rest shown there. And more importantly, that the outcome is improving, that residual mitral regurgitation. Less than 2% is almost in everyone, 98, and less than 1% in 77.5. Gilbert, want to make comment on it? Less than 1 is 77.5.
Yeah, no, there are lumbar limitation with this paper because first of all, it spans 3-4 generations of mitral clip. This is not G3, this is not G4, it's only a small percentage. 2 is that it's all operators, all comers in the United States. And so, there's definitely the reason why you see only 66% at 30 days of 1+ or better MR. So before, you don't have the technology to optimize your MR repair. Now you do. And so really, there's no excuse now in our mind that you should have 1+ or better in primary or even secondary MR if possible.
Beautiful, and that is what we will show. We're reaching there, and basically they could talk about the success is 2. Less than 2 equal or less than 2 plus mean mitral gradient of less than 10. As you saw it, then you can measure the mitral gradient, and this actually had translated into a various degree of outcome. Success rate over the years, you can see here from 2014 to 2022, a significantly increased from 81 to 92%. And of course, the volume, which is on the bottom, has increased also. So about roughly said that about 16 to 1700 of the mitral clips are being done overall in United States per month. About little less than 2,000 at present. Now mortality, if you are successful, unsuccessful, clearly shows that it's a double. If you are unsuccessful, successful 14%, which is good. And remember, successful is 2 or less mitral rigors plus gradient less than 10. And this translates into heart failure readmissions. And so also, whatever your residual mitral regurg or the gradient outcome are there. So key is you have good results, less gradient, your 1 year survival is the 98%. And sorry, 88%. So this is a success overall in the trial, taken all people together. And of course, you see some of them have mild, moderate MR and unsuccessful in about 11% of cases if we take all the patients together. So then also for the degree, so according to MR success, so same, that whatever degree is mild, none, and of course with the gradient, all are speaks for there is a gradient of survival. So better is low gradient and less than 1 plus MR. And this emphasized that over the last 8 years, I'm reading the last line, 8-year period during the study, the procedure volume and success rates increased significantly, reflecting procedural refinement and device improvement. And this is where we are now. Now then, there is some data came that we always wait till end stage for the heart failure patient for the functional MR. The question is, should we be waiting that? They have 4 stages. They have come up with a stage 1 when their LVF is low and LVDP is high. Stage 2, there is LA involvement, and in a stage 1 there is no LA involvement. Both LA involvement, and then stage 3 and 4 where you started having a volume overload. And question comes that if you do it in early stage, although there are very small number of patients, you get the best benefit. So always question comes, just like for the tower, you are asymptomatic but you have severe aortic stenosis. Should you wait? Right now we all have been taught you have to be on guideline directed medical therapy, and then follow up. And we have seen patients that some improve and many of them they lost follow up and they come back 1 year later. Now their ejection fraction from 55 has gone down to 20. So question comes, you have severe functional mitral regurg. Should you wait to get a pressure and volume overload of stage 3 and 4 or the biventricular failure? What do you think? I will ask actually our echo colleague also Stam on this point.
Yeah, I think earlier is better. Because if the ejection fraction drops, one of the exclusion criteria also for this clip is ejection fraction. So that means that the lower ejection fraction, the worse the outcome will be after you do it. So I think the earlier, the better is for everything else, or the valve disease, the sooner the better.
Yeah, so good. That was the conclusion.
Yeah.
And the second is now the edge-to-edge, the expand registry. What basically is, I already mentioned, the NTR and XTR and of both classical versus the new generation. And they actually have done, by using those, the overall the large number of patients from the registry and used for both primary and secondary MR, XTR. What is the most common clip we use at Sinai at present, knowing that we do now this year we should do about 100 clip procedure, mitral clip, which is the most common and what is the second?
So it depends on that, but G4 is G4. I would say XTW is the workhorse clip.
Okay. So
the bigger and wider.
Bigger and wider. So that's the simple answer, because that's why many times we think 2 clip and we come out with a 1 clip on those cases. So procedural success of the expand, as you can see, significantly improving, and of course the procedure time is going down. So this is the whole purpose and length of stay. Fluoroscopy time, everything gets better, lower residual mitral regurgitation with the bigger clip. And comparative data from by other studies with the TVT registry co-op for the primary and secondary MR using this bigger clip has a better outcome. Really this has led to another multi-center G4 post-approval study, which basically are putting together all the data of these patients from international point of view. All these patients are symptomatic, we all know. And question is that if you have a tier suitable and tier not suitable, where there is a risk of stenosis or inadequate MR reduction, there also it helps. Any comment from both of you on this issue?
Yeah. Dr. Kinney, want to
even the cases that we see? The bigger clip is allowing you to take some cases which would not be done in the past?
No, that is true, especially I think in secondary MR where you have dilated annulus. In the past, with a smaller clip, third generation and all that, we were not able to take on those cases. But definitely with the increased length and wider, That is how we were able to do this tougher
Yeah,
cases.
Stem,
But going back to
let's
your
hear from
question
Stem.
also,
How many, like, quote unquote, yellow cases we get, right? Green cases, almost, we don't ever see them.
we don't see
You want to
that.
comment on the complexity? You seem to see all the echoes.
Yeah. I mean, it's evaluating these patients are very difficult,
Yeah.
and so.
But I think the complexity is high.
High, very,
right?
very high. Yes.
In terms of the hill, you want to make a comment about, they talk about green, orange,
Yeah,
red,
no,
right?
I think the biggest benefit we
Yeah.
have now with so many choices available is if you look at the concept behind the procedure, which was the Alfieri stitch. Unfortunately, only Alfieri was the one who was able to reproduce the outcomes. Rest all thought, adding annuloplasty to the Alfieri stitch would give you the best outcomes, which was reproducible. So I think with these wider, bigger clips, you are able to achieve annuloplasty as well as the stitching of the leaflets. So I think there is definite benefit of having these choices, and especially using the bigger clips in some of these cases, especially secondary atrial MRs.
And that is a good point, that now we use less clip, I mean a smaller one clip, and then lower time used and less gradient, and of course a lower regurgitation which happens. Now, there is another interesting, the impact of mitral regurgitation etiology on mitral surgery after tear. You got the tear, now failed. Now the patient needs the cutting edge registry was to get these patients follow up, what happens to them. And as you can see, the numbers are increasing because more cases, clips are being done. They both are kind of equal, both for primary and secondary MR, as you can see there. But the important point, of course, from a risk point of view, we all know that functional or secondary MR will have a higher comorbid conditions compared to primary MR, and when they go for, and of course the ejection fraction point of view, and particularly what I've seen, that once you failed your clip, it's about 3.5 months, around 100 plus days, then patient continue to be symptomatic and they go for mitral valve surgery. What is our experience here?
Well, we've done a few, but most, stenosis is one. I think that's important. But the secondary arm is that you cannot clip more without causing stenosis. So they have a ventricular disease, right? It's not a primary disease. So those we have to manage. But almost the key message, almost all of them get mitral valve replacement. Like maybe around less than 10% you can repair the valve. So the message is that, if you want to do TEER, you want to do a good job from the get-go. You don't want to do a suboptimal job and then you have to have surgery, because surgery is very high risk. I'm sure Dr. Sharma will show the slide. It's a very high mortality associated with secondary MR over primary MR in this paper.
And most of these ultimately go for, because there is a still regurgitation remains, and then the question comes is here, mechanism of the tear failure is a loss of leaflet, insertion single leaf detachment, then partial detachment, clip embolization, but majority are mitral stenosis, residual MR, and recurrent MR. So those are the major, they makes it 70-80%. Everything else is very small. And that kind of equal both functional and degenerative. So I felt that maybe the residual MR leading to surgery will be more in the functional MR, but it's secondary MR, basically they call it here secondary SMR rather than FMR.
Right.
But it was not the case.
Well, that's residual and recurrent, right? They're two different things. So residual you leave the room with MR, and then recurrent, they come back.
Right.
But also we noticed that there's more stenosis on the secondary MR side.
Right.
As well.
That is true. Secondary more stenosis, but residual MR were equal. In both of them requiring clip. And 30-day mortality, as you can see, clearly higher in our structural versus primary. And one more thing I wanted to show, and that's the point you made. Why we go? 1 second. Yeah. That what do we do? Most of these cases, then surgical approach is basically the replacement of the valve.
Yes.
See, mitral valve replacement or repair, 90+% gets the replacement, and repair is done in very small.
That's right.
So that is where, and then of course with the particularly in the degenerative, there is no repair actually.
Yes.
It's almost a replacement. So this is another mortality, and so this basically is stratified, is very important. Overall, it's a risky procedure now. You think about 3-year, 32% mortality. And it's a big difference in the functional or secondary. As you can see, primary MR, 80% survival at 3 years, while if you are secondary, it's only 40%.
Yeah, they're sick patients. I mean,
Yeah,
that's
they're
why we
sick
don't
patients.
operate on them
Yeah.
anymore.
So that's it. So, and I'm surprised they actually did, and this nice graph, central figure shows all these points that if the secondary MR has to go for surgery is higher risk, and it usually happens just because of the continued regurgitation, as you can see here, mechanism of failure. So this is the cutting end. It's very important. The risk of mitral valve surgery after TEER is non-trivial, with higher mortality after surgery, especially in secondary MR patients. These findings provide valuable data for further research to improve this outcome. So then question comes is that if it is a bad etiology, should the patient go for surgery, which is like same thing, which we always talk about, but all these patients went for the clip by definition because surgery was not appropriate at that time. But once you failed, you had to go.
Yeah, I mean, either you tell them no, we can't offer anything, medical management, or you trap to do high risk surgery. So.
Okay. Good. And then we have you remember the Pascal is the new device we have showing good data of initial Pascal implant. And then there is a small randomized trial which showed Pascal 2D about 200 patients overall showing the data that clearly maybe the device issue, that mitral clip faster, we all know, compared to the Pascal, and rest of the data looks like similar complications and so. And this is the short endpoint and safety, but equal, effectiveness equal, and this is actually Sinai data. As you can see, we have over last 6 months, if we take Mount Sinai Hospital versus National TVT Registry, the biggest effect I would say here is one, the average device time, less than half of the country, 25 minutes. Today was what, 12 minutes,
Yeah.
15 minutes or
15 minutes.
20 maximum. And the second point at the bottom, of course, we do great in terms of average MR reduction, which is 1.1 versus 1.3. That mortality, 30-day mortality is 0%. And 1 year was 5%, which is 3 times higher for the national. So this is a tremendous, I would give a thanks to our great structural team. All the members are right here in this room. So just lastly, quickly, that like everything else, there is score coming up, co-op risk score by from the co-op trial by Greg Stone, which takes COPD, AFib, heart classification, CKD, LVEF, right ventricular pressure, TR, and all those takes into account, and then you can have a score from 3 to 15 and gives a follow-up 2-year death or heart failure. So with that note, Abbott actually had asked Anu, she is a master of making the risk, the app to create an app, create an app for the co-op risk score. So purpose there is you can better plan your strategy.
Which patient should be getting what kind of treatment? So as I have both the interventional cardiologists, surgeons, and heart failure people, everybody can use that app and give a risk score. And when they're discussing with the patient, outcomes will be will come out as a PDF that they can discuss with the patient. That if this is your risk and this is going to be your outcome, and we document that in the EMR.
Beautiful. Another risk is from the Mitro Pro from German registry with from the residual mitral regurgitation. This is also took the mitral score less than 3 or more than 4. These are the ingredients of that score: echocardiographic, MR grading, LA pressure monitoring, LV angiography with the MR regurgitation, echocardiography, and LVOT, and various other factors, which is 1, 2, 3, 4 total score, and shown that if the score is 3 or 4 and above, is associated with 1-year mortality. So key is the lower score. Of course, everybody wants to have lower score compared to the higher score, and so. And this is very interesting, that maybe the question comes, once you have such a higher mortality of 50% at 1 year, should you not be doing the case? Right? I mean, there's always question comes out when we do a, let's say, valve in MEC. They have a very high mortality, maybe you don't do anything, maybe the patient might be okay, but this always remains the issue. But at least scores are there now, will be available. Apollo, we are part of it, Intrepid TMVR. which is the transseptal, having a great success. How many cases we have done so far?
I think almost 10 now.
10.
Yeah.
And you see the 30 data which we presented before. There are no PVL. There was a vascular complication and ASD. Those things are being worked. Vascular complication was the big one, but very good device. Little cumbersome, but that's the, any new device happens, then a very large sheath. That's the key. And of course, one of the device has been stopped at present because of the issues, but we continue to do. And 1 year data will be presented in TCT this month. So another inno valve, which is that there is a lot of restriction of various valves, and this actually works in the very simple, innovative way. And they showed the cases in European Society of Cardiology that is basically transseptal, and you see go through the same for the mitral valve and comes out in various prong approaches, as you can see there, and try to take all your leaflets, very little, and then it opens up the valve there. So after taking all the chordae and make the valve. So seems to be something apparently cause immediate improvement in ejection fraction. Patient with a low EF, but need to see a little more in these particular cases. So this is the trials are ongoing at present with a twist trial to see how it's going to behave. So let me just complete my presentation with a 5-year co-op trial. As positive, even you receive the clip after 2 years. As long as you make it to 2 years in the trial. Secondly, the TVT registry showed the learning curve and great success now. And of course, dependent on residual MR and the gradient, and better outcome always in the degenerative MR, and TR availability in the better outcome of the mitral valve surgery. And then lastly, baseline procedural scores able to identify the patients who will get better outcomes after TR and will help in planning. So very quickly, 3 questions. Following statements are correct for 5-year outcome of the co-op trial for moderate to severe MR, except sustained benefit in heart failure and death, sustained lower mortality, benefit after 2 years, landmark analysis decreases in the device group, and patient who received device after 2 years had poor outcome as the original device group. Answer that wrong is D. Even after 2 years, they got the device, they had a similar outcome as if they had a clip originally. Second, this statement is true regarding the TR outcome in the DMR versus FMR. Significant reduction in MR up to 1 year in both groups. Significant reduction in New York Heart Classification. Similar mortality at 1 year between DMR and FMR, and procedural success continues to increase in last few years. Clearly, the difference is in the mortality, higher mortality in the FMR versus DMR. Then, following statement is false about the concomitant TV and mitral valve TR. So this is actually overall was a combination of both, and basically showing that B indicated in combined pre and post capillary pulmonary hypertension patients. So with that note, I'll stop here, and any questions we can take.
Yeah, very last talk. One question. How about the future of the TAVR procedure in a trial FMR? Because the number is not real, especially in China. Do we think the TO is? I think it's doable, but how about the durable and the benefits to this particular group patient?
So I mean, if we take the patients of the co-op trial, and now we go up to 5 years, so those are the tier, that is still what done with the old devices. So it still remained, the mitral regurgitation still remained low. I mean, it's there, but continues to remain low. The device-related safety remained good. So I think those are still, once you achieved good outcome, I would say it's sustained.
Yeah, what do you think?
No, I think, like you showed the green and yellow, right now we are going orange and red. I mean, red almost outcomes are bad. If you start doing yellow patients, then I think we will see a better outcome in these cases. And that is true when we are seeing these patients, they're already on medical therapy. They come to us on if they have MR on medical therapy. So only thing changes is they'll continue medical therapy with a decreased dose of the medications. But if we see a success, I mean, usually 70-80% have a good improvement. between 20-30%, you never see an improvement. They are probably orange and red patients.
Yeah.
So I think that's where our movement has to be, that start taking these cases early on. Definitely then we will see, patients will benefit better rather than wait on GDMT.
Yeah, early on is one important point. I think the difficult part is convince our primary care doctors and cardiologists because of the other newer class of GDMT. And with mitral clip and tear, you know that there are three issues with secondary MR. One is it's a ventricular problem or it's an atrial problem. Right? You cannot fix that with just MR alone. We've actually asked our EP colleague, can you fix the AFib? And they're very reluctant because it's a chicken and the egg. Just like ventricular disease, you need to have GDMT, and most patients, and same as in China too, right? You cannot afford the medication, or they don't take the medication. They think, oh, I feel better, I got a procedure. And then the MR comes back, they got heart failure admission not because the procedure failed, but the holistic care of the patient failed. So I think that's what we need to emphasize to our community, that it's not just a procedure, but with secondary MR, you have to treat the whole patient and you have to maintain that. And that's why co-op was successful. Every little change was documented. It doesn't happen in real life.
And that is true. There is a paper actually which I did not include, that once your clip is done, mitral clip, at 9 months, 6 to 9 months at time period, while there is a GDMT, 90+% compliance at the time in 30 days becomes less than 50% after 6 to 9 months. That's but life. I mean, I don't know what we can change it, but that's where some of those patients are the one who is going to develop symptoms sooner than otherwise.
And we see that in office.
And we saw it quite a bit. Yeah. All right, Pedro, all yours now.
Very good. Well, thank you very much for the heart team members of the Cath Lab for this super exciting case. Thank you also for our co-moderators in China, Dr. Mao and Dr. Yang. And most importantly, thank you guys all for joining us for this exciting case. Most importantly, this afternoon, this case will be already available at ccclivecases.org. And last but not least, our structural life cases occur in the second Monday of every other month. So our next one will be December, I'm sorry, I apologize, second Tuesday
December 7th,
of
right?
every other month. And our next one will be December 12th at 9 a.m. Thank you so much.
Bye-bye.